Good morning, everyone. Thank you so much for joining the Association of General Practitioners' very first conference. And it is all about the blood. It is all about the blood. And we have a wonderful lineup. We have 2 sessions. I'm moderating session 1, and my colleague, Dr. Arna Brown, is doing this session 2. So the conference is on Hematology and Ethics 2021. And in this session, we have 2 very wonderful speakers, Professor Jennifer Knight-Madden and Dr. Rochelle Roman. So the first presenter is going to speak about management of sickle cell disease. I know you've done your pre-test and you got some right and maybe didn't get some right, but she will enlighten us further. Professor Jennifer Knight-Madden, she's the Professor of Pediatric Pulmonology and Clinical Research Director of Sickle Cell Unit of the Caribbean Institute of Health Research. He's also co-chair of the Sickle Cell Working Group, Sick Kids Caribbean Initiative, and Vice President of the Caribbean Network of Researchers in Sickle Cell Disease and Thalassemia. She's a board-certified pediatric pulmonologist. She's a graduate of the University of the West Indies Medical School in 1988 and completed her training in pediatrics at the Hospital for Sick Children in Toronto, and did a fellowship training in pediatric pulmonology at Duke University Medical Center. She also completed an MSc in biometry and a PhD in clinical research at King's College London. She joined the Sickle Cell Unit in 1997 and the TMRI Now Care in 1999, and has been involved in both the sickle cell cohort study and the Jamaica Sickle Cell Unit birth cohort study. Her current research interests include pulmonary complications of sickle cell disease, clinical trials, and implementation research. My friends, my colleagues, Professor Knight-Madden is put on record as very distinguished in presenting original work. She's recognized nationally and internationally and has enhanced the ranking of the University of the West Indies in international circles. She publicly shares her knowledge. If you go on YouTube, you will see Professor Madden speaking to the public. She has been involved in many programs, including the universal screening of sickle cell disease in Jamaica, and has allowed Jamaica to join the superpowers who also do this. So please help me to welcome Professor Knight-Madden. Professor Knight-Madden, over to you.
Thank you so much. Before you go, Professor Knight-Madden, and thank you so much for that introduction, Dr. Buckland. Dr. Gordon had some technical difficulties and he's on. He would just like to give everyone a welcome and say hello. Dr. Gordon?
Thank you, Sam, and thank you, listeners. Good morning, colleagues, presenters, panelists.
Good morning.
And all the very distinguished attendees. Welcome to the AGP first webinar for 2021, Hematology and Ethics. Having successfully navigated 2020, we at AGP want you to have a safer and less stress-ridden 2021. It has been a challenge to stay safe and relevant in these times, and so we'll continue to do these webinars until it is deemed safe to engage in face-to-face on a face-to-face level. Today, the webinars have been very successful as we have seen a significant increase in all the participants. As president, I must extend my appreciation to the distinguished presenters, Professor Knight-Madden, who has already been introduced, Dr. Angela Scott, Dr. Rochelle Roman, our panelists, Dr. Andrew Manning, Dr. Brian James, Dr. Lyndon Leach, and Dr. Peter Swaby, who all agreed to give generously of their time to make the webinar possible. My kind appreciation to our very own colleague and of AGPJ, the moderators, Dr. Aldit Buckland and Dr. Anna Brown, who I have no doubt will skillfully guide these sessions. Finally, a big thank you and participation to Sam, technical team, and Administrator Lynn, who will ensure that you all have a smooth and beneficial experience this morning. Having said that, I will hand you over back to Professor Knight Madden to continue our presentation. Please remember to do the pre and post test and also to participate in the polls. Have a wonderful conference. Thank you.
Good morning, and I'd like to thank the Association of General Practitioners of Jamaica for inviting me to be a part of this conference. I hope you all can hear me properly.
Yes, we can hear you properly.
Thank you. So, thank you for giving me an hour. And, then it became really difficult to figure out what to do and what to leave out. But hopefully I will cover the things that are of most interest to you all. So we will be, I am just having a little problem here. Let me just put it on. There we go. So we'll run through the definition, the epidemiology, then we'll look at a life course approach as a general practitioner looking after people with sickle cell disease. And then I've touched on a few sort of areas that I can't give a talk and not talk about. So sickle cell disease and pain, acute chest syndrome, therapies for sickle cell disease, and in this time, of course, COVID-19. Then I will end with some clinical pearls, some things that I just want you to remember as we close, and an invitation to another opportunity for learning about sickle cell disease. So sickle cell disease is actually a group of disorders characterized and caused by the presence of hemoglobin S. So in the sickle erythrocytes, more than 50% of all the hemoglobin is S. And S, as we all know, is based on a mutation in the beta chain. What it is not sickle cell trait. Sickle cell, in people who have sickle cell trait, more than 50% of their hemoglobin is A, and so that is not the disease. We all know that it is autosomal recessive, and so each parent should have at least one abnormal gene, of which at least one must be a sickle gene. The various forms that are most common are listed here. In Jamaica, SS1 in 325, SC 1 in 500, and then S beta plus thalassemia and S beta not thalassemia. In Jamaica, we do see some quite rare types, such as SO Arab, SD Punjab, and so on. How do we diagnose sickle cell disease? Well, technically, looking at the DNA is the ideal way, and that's becoming more popular in developed countries, but it's not very common, it's not available here. So here we actually look at the protein, the hemoglobins that have been formed, and look at their different properties. Everybody's familiar with hemoglobin electrophoresis, and we would do CAM and agar, so alkaline and acidic. More recently, we do other methods, including isoelectric focusing and high performance liquid chromatography, which is crucial to our newborn screening. If you have a child who comes to your practice with the results from newborn screening, it's very important to understand how to interpret them because it's different from older people. In the newborn, hemoglobin F is by far the most abundant hemoglobin. And when it is reported based on abundance. So the first letter will be the most abundant hemoglobin, which is going to be F, and then they are reported in order of abundance. It's important to note that some phenotypes that we see at that stage actually may indicate more than one genotype, and so we will need to confirm later on, and that the diagnosis of thalassemia often requires additional tests. So here we have some of the common results that you may see coming from a newborn. FS is very important because this is what you will get with SS disease. However, of note, S beta not thalassemia, where this thalassemia gene makes next to no hemoglobin, will look identical. particularly in premature babies and in babies where the thalassemia plus gene hasn't started to make hemoglobin yet, they can still have FS as a newborn. And S, hereditary persistence of fetal hemoglobin, will also be FS. So we have to sort that out later in life, by the time they're about 1. But until then, we treat all of them as if they have SS disease. Now, FSA, you note that the S is before the A, so there's more S than A. And so this is in fact S beta plus thalassemia, as against FAS, or sickle cell trait, where there is more A than S. SC is pretty straightforward, and of course we can get the C trait and actual CC disease, which we would send on to our hematologist friends. So we're now going to have a chance to look at question 1. So I'm going to ask the poll to come up. Are we seeing the poll? Yes, there we go. I'm sorry about the lack of a symbol. This is actually S beta.
All right, so we'll just run the poll for another 15 seconds.
Okay. Okay. So we'll see what people have said. Yeah, there you go. We're good to go. Almost everybody has that right. Excellent. So how important is sickle cell? Actually, both the World Health Organization and the United Nations have said that it's a global public health issue. The highest prevalence is in Africa, and next to Africa is actually the Caribbean. And if we look at Jamaica, we will see that 1 in 10 of us have a sickle cell trait. Another 5% of us have another trait that can go together with an S to make a baby with sickle cell, so C or thalassemia and so on. So 15% of Jamaican adults are walking around at risk of having a sickle cell baby. So all of us, all of your patients, every adult in your practice who is of childbearing age should know what their status is. And then, of course, 1 in 150 will have a form of sickle cell disease. This is just to say that wherever the blood goes, sickle cell disease can cause a complication. So I don't think it affects the hair because the hair is already dead. But anywhere that the blood goes, you can have acute complications or chronic complications. Clearly not all, we can't cover all of these. And these are just a sample of them. This is not exhaustive. So we're going to hit the ones that are really important. And we're going to do this by looking at the different stages of life and bearing in mind that the median survival is about 42.3. You know, people with sickle cell disease start to have chronic disorders and what you would think of as middle-age problems, renal failure and so on earlier. So that interface is a little bit elastic. And for each stage, we're going to look at anticipatory guidance because that is the most important thing. You know, we all will take our history, we all will do our examination and so on. But with people with sickle cell disease, anticipatory guidance is key, as with any chronic disease, doing the right screening at the right time, making sure that they're aware of the complications and when we need to refer or co-manage. So here we have the infant. This is not easy. The initial counseling about sickle cell disease, what is it? The genetics of it, ensuring that the parents will take care going forward, but that they're not feeling guilty about having this child who's now affected. And then of course you do the usual well baby counseling, but the vaccines are different, so you have to stress those and counseling about important complications. So in the first year of life, you're going to have the Prevnar starting as early as 6 weeks of age, certainly by 2 months. So this is why getting the newborn screening result quickly is important. And then by 4 months, we're going to penicillin prophylaxis, and we've taught how to palpate the spleen. So that's very important. By just 9 to 12 months, as I mentioned, for SF, we're going to do confirmation, and we'll be doing CBC and iron studies, because we do need to have a CBC for comparison as we go along. So the most important complications at this age are pneumococcal sepsis or invasive pneumococcal disease, acute splenic sequestration, acute chest syndrome. These are the dangerous ones. And of course, dactylitis, which is the way that infants who are not screened at birth would most commonly present. The natural history is well described. So in the first 6 months of life, very few children are symptomatic. But as early as 2 years, a majority of children have had symptoms. And as the vast majority by 4 years. And one of the problems is that sometimes when you look back, they actually have presented and have been treated, but nobody thought of sickle cell. So we have to think of sickle cell disease when they present with the complaints. And remember that the peak incidence of death is in the first 3 years, first 3 to 5 years. So it is critical that we actually do newborn screening so that we can improve morbidity and mortality. Now, in the toddler preschool age, we think more of the complications as well, but diet, growth, development, no iron supplements, no soft eggs, chicken must be well cooked, no pet lizards. So we're thinking of salmonella, and of course, the vaccines, because we're going to get our boosters. So children with sickle cell disease do get a Hib booster at 15 to 18 months, and their Prevnar booster. When they're 4, they're going to get their Pneumovax, and they're going to continue penicillin until they have had that Pneumovax. So if they don't get the Pneumovax, they continue the penicillin. What is really great is that the Ministry of Health now makes that vaccine available without cost to the patient. So that is wonderful. People used to have to save for it. And we may have introduced hydroxyurea, and we continue to palpate the spleen. When we look at investigations, we're now involving transcranial Doppler, and we know as we get towards 4 and 5, we'll be looking at renal function, liver function, and urinalysis. So these are routine screening tests for children with sickle cell disease. And in addition to the complications we discussed before, we're now starting to see painful crisis. With the big spleen, there's a question of chronic hypersplenism, and that will affect their growth. Strokes, which strokes and leg ulcer, I struggle. Those are the 2 horrible complications of sickle cell disease. And these strokes can be clinical or they can be silent. So as many as a fifth of children with sickle cell disease will have a silent stroke. So they won't get that motor change, but it may affect their cognition and so on. Enuresis, because they are now 5 and up, and wheeze or asthma. I'm not going to get a chance to really talk about wheeze again in this talk, but it is important. If a person with sickle cell wheezes, they are more likely to get acute chest, more painful crisis, and even die earlier. So it's important to pick up on wheezing and to treat it aggressively. So acute splenic sequestration. The spleen gets big suddenly, all the blood goes there, there's not enough blood for the baby, and they can go from running around to dead in a day. And this is a very simple thing. You teach the parents to feel the tummy every day when they're bathed, and if they have it, they come in, they get transfused if necessary. We use this very major bit of technology called a spleen stick, which is actually just, our usual tongue depressor. Write the name on one side and their baseline hemoglobin on the other side. As you measure, you will, in the midclavicular line, vertically, and mark where is the lowest point that you palpate the spleen and put the date there. And the parents can do this at home every day. And if the spleen gets larger, they can come back in. And look at this. I think this has got to be the cheapest, best intervention in the world. So before teaching parents how to palpate the spleen, there were 4.6 episodes per patient year, and more than a quarter of them died. And subsequent to that, with teaching, we saw more episodes because the parents were aware. And look at what has happened to mortality. Amazing. So every healthcare worker, doctor, nurse, whoever who looks after babies with sickle cell disease, every time you see them, you go through this with the parents, because this is what we want to avoid. Similarly, the penicillin is important, and in fact, our own incidence of invasive pneumococcal disease is lower than in North America with the approach that we have. And again, this is what we want to avoid. We want to avoid having, this is actually meningitis. We want to avoid that. As I mentioned, we start Transcranial Doppler. This is done at the sickle cell unit. It's a simple, non-invasive test, and it has real sensitivity and in predicting risk of stroke in children. And it's an ultrasound. So it's a little desktop machine. You can see the probe here on the child, and this is what we're doing. And if it's greater than 200, then you are actually going to initiate therapy because the risk of stroke is so high. So overall, this is what we come to. In the first third of the cohort, you can see that by the time they were 5, already 20% of them had died. That was cut by more than a half with the second and third tertiles of the original cohort. And with JANSCOB, you can see, which is the more recent cohort, that this is much improved. And even these data are old and are probably improved since then. So Dr. King has published that, the mortality of up to 5 years of age, if you're diagnosed at birth and treated at the unit or treated the same way anywhere across the island, the mortality is the same as if you don't have sickle cell disease. So we have to get this to every nook and cranny, to every practitioner, so that all our children will have access to these very inexpensive interventions, which makes so much difference. So now you're into the school age. So some of the same stuff, but now we're starting to talk about puberty, right? Because, in Jamaica, some of our girls, by the time they're 9 and so on, will be going into puberty, and it's delayed in many people with sickle cell disease, but also issues of jaundice. So visible symptoms of sickle cell that may start bullying, bathroom breaks, the teacher allowing them to go because they need to drink more, so they need to go more. They may or may not be able to do physical education. If they miss classes, how will that be made up? So these kinds of things become the clinician helping the parents to help the child to navigate this arena of school. And of course, we may again be on hydroxyurea and folic acid if needed, particularly for people with chronic hypersplenism and so on. In terms of the investigations, the ones we've talked about before, and now we're adding in ophthalmology, looking at peripheral sickle retinopathy, and we are talking about psychoeducational testing. I mentioned the silent infarcts and so on. So we have to really ask about schooling and make sure that if they're falling behind, they're tested early, they can get accommodations and so on. And at every stage, having this disease is very stressful for many people, for the parents, for the children. So if there's any need for psychological support, that needs to be provided. So again, the same sorts of complications, but no, the enuresis is really becoming a problem. If you're 10 and you're wet in your bed, you can understand that this will cause problems. So it's important that you discuss with the child and the parents that this is actually a complication of their disease, and it's not that they just don't care. Okay? As I go into adolescence, it becomes a challenge. I mean, any teenager, being a teenager is hard, right? Because, all sorts of things are happening. Add into that this kind of a chronic disease, and it becomes very difficult. So in addition to our other school things, we have to be talking about depression and suicide, because we do know from data locally that the rate of depression and parasuicide is actually higher in our children. Career choices. We don't want them to want to be policemen, firemen, pilots, things that they can't be. And of course, relationships and pregnancy, because, sorry about that typo, because of the risk, the high risk of pregnancy in women with sickle cell disease. And now we're starting to see some of these other chronic complications like leg ulcer. You can have delayed puberty. You may start to see avascular necrosis of the femoral head. Stick up in. I just have to say, if you ever see a patient with sickle cell with pain in their hip or their knee, always examine the hip carefully, because the pain can be referred to the knee. And if they're having a painful crisis in the head of the femur and they weight bear, the rounded head will become square and it will be in a round peg. So it will literally be a square peg in a round hole, and they will have pain for the rest of their life unless they have it replaced. The simple solution, when they have that hip pain, no weight bearing, so they go onto crutches. And then we go into young adulthood. So again, we're talking about all these other things, but not so, maybe still school, but maybe vocational achievement, what is possible. You have to remember contraceptives for the women, because as we said, pregnancies are high risk. And at this stage, this is when painful crisis tends to be at its highest. So those who are severely affected, who have not gone on hydroxy or who it hasn't worked for, you may need to involve the pain clinic. This is when you may also start to need an internist, a nephrologist, a cardiologist, depending on what is happening. And of course, if they are pregnant, high risk antenatal care. Middle age into elderly. No, you're looking at, what have they made of their life? Are they able to look after themselves? Because by now their parents have passed and they have to be self-sufficient. And in terms of the complications, we're seeing more and more of these chronic complications, renal failure, heart failure, so on, that are really very difficult. Leg ulcers are difficult, very difficult to live with and very chronic. So as I've gone through the life course, just to say that, as I mentioned before, there are some things that change with age. So in terms of the screening as neonates and then as they're older, and in terms of hematology, it changes so that it settles down after they're 5. And that's when we talk about their steady state. This is just one of the tables available in the clinical care guidelines. Similarly, you want to remember, if you're looking after the child with sickle cell disease, the special immunizations, the Prevnar, the Hib booster, the Pneumovax. Just have to remember those. All right, so that is the first sort of part, and now we're going to go on to some special topics. Can't talk about sickle cell disease without talking about pain. Pain is pain. The person who has it knows they have it. The person who doesn't have it, they're not sure that you have it. So it comes unsharably into our midst as at once that which cannot be confirmed and that which cannot be denied. And this is one of the huge problems with sickle cell disease, is when people don't believe their pain. So believe their pain. And the pain can be acute. Some of these things like priapism, acute chest, a painful crisis, right upper quadrant syndrome, or it can be chronic, leg ulcers, intractable pain, lower back pain. They can have collapse of their vertebrae, chronic hepatomegaly, vascular necrosis of the head of the femur. So pain in sickle cell is different from most pain, right? Because it comes back to vaso-occlusion, where you have hypoxia, ischemia, and then tissue damage, followed by chronic vascular inflammation. So you have all these inflammatory mediators, the reactive oxygen species, and all of these things being released, eating up the nitric oxide and causing damage. And so it actually also it gives a signal of pain, and over time can actually affect the nerves themselves, going to neuropathic pain. So it is this combination of hypoxic perfusion injury, ischemic tissue damage, and inflammation that makes this pain unique and different. It can be acute, which is the #1 cause for hospital admission. It can be chronic, and that chronic pain can be obvious where it's coming from, leg ulcers, a vascular necrosis of the head of the femur, or it can be persistent, it can be intractable. As people with sickle cell get older, pain becomes more and more of a problem. And sometimes they even have neuropathic pain. So it's tingling, burning, shooting, and adjuvant therapy here may be very helpful. That's a whole nother talk just by itself, pain in sickle cell disease. But for neuropathic pain and for, in some cases, it's important that we use different medications, such as even anti-seizure medications. So just some pictures here. This is what dactylitis looks like. And as we said, if they're not screened, this is often the first sign. And we use this picture just because I think you get the feeling of pain. And I tell people, Dr. King doesn't like it because she says I'm underselling it. But if you think of the worst chikungunya anybody you know had, and double or triple that, that is life of some people with sickle cell disease. You wake up in the morning, do I have pain? If I don't have pain, will I actually go through the day without pain? It's just an uncertainty. It's really difficult. So the ABCDE: ask and assess pain. Believe the patient and their family and what relieves it. That's important. You know, there is no narcotic that treats every patient. It depends on their genetic makeup and what enzymes they have or don't have, and so on. So believe them. They know what works. Choose the appropriate pain controls. Deliver it in a timely, logical, coordinated fashion. Give it fast and give it often enough. Don't make them wait till they're screaming in pain to get another dose. And empower the patients and their family. So, pain assessment tools. So it's good to have an objective measure. And even in a child, you can use the smiley faces, and you should look at the site, whether it's typical. So you can say to a patient with sickle cell disease, is this bone pain? And if they tell you no, go find out what is going on, because they get to know what their typical pain is like. What have they had? They don't like to come to the clinic, if they can stay home. They definitely don't want to go into hospital. So they would have taken what they had, find out what they had, and of course, allergies and contraindications. Screen for other complications that may be causing the problem, and always look for things such as dehydration, infection, hypoxia, changes of temperature, psychosocial stressors. Choose the right one. Use the non-analgesic. So warmth, hydration, distraction. Like sometimes you will see a patient of ours sitting down, on their cell phone, da 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 da. And you look at them and say, that person cannot be having severe pain. But they have learned to try to distract themselves so that they can deal with the pain that they're having. And of course, treat comorbidities. We're all aware of the ladder, so I'm not going to spend time on that. Okay. So we would often use, and you start with the lowest and you add on, and then when you are getting better, you take away the most potent and come back down to the lowest. So you don't just stop things all at once. So acute chest syndrome in anybody else is pneumonia. Okay. So you have to have sickle cell disease, acute onset of pulmonary symptoms and/or signs. It requires an X-ray which shows at least a complete lung segment having alveolar consolidation, and it is common. So at least 50% of children by the time they're 10 with SS will have it. And even the milder types, SC, at least a third of them in the cohort had it. It's a common cause of mortality, and it's one of the things that really can be decreased by hydroxyurea and chronic transfusion. And recurrent acute chest is the most important predictor of developing chronic lung disease. How do you treat it? Admission, oxygen, because they're hypoxic. If they are, so you need to know what their baseline saturation is. Fluids, enough but not too much. Antibiotics, the right ones. Physical therapy, transfusion if necessary. I mean, like what other pneumonia do you go around doing an exchange transfusion for? This is why acute chest is not pneumonia, because the host is different. The same infection that might cause, a mycoplasma up and down can kill somebody with sickle cell disease. So they're more prone to it. They need different medications or therapies, particularly transfusion. And the cause of it may be infection, but it doesn't have to be. It could be pulmonary fat embolism. It could be infarct. It could be sequestration. And so even though it looks like a pneumonia, it is an acute chest syndrome, and you treat it with a lot of respect. So you're out there in your practice and you see somebody and you're convinced they have acute chest syndrome. Do they need to go to the hospital right away? The default is admission. The default is admission. But if you know the patient very well and you can see them frequently, and there are a lot of things in place. So we do not admit every patient. If they have none or minimal respiratory distress, SATs that are normal for them, their CBCs at near steady state, they can access urgent care at any time of day or night. And the parents or patient have the knowledge and attitudes to do the right thing, then you might not admit them immediately. But you have to know them. And this is where GPs have, you know, that edge over most places, because you know your patients and they can come back to you for review. But the default is admission. All right. So acute chest syndrome, painful crisis, one of the ways that we try to change or modify the disease is with the therapies that are now available. And I mean, like, it's unbelievable. 3 years ago, the talk would have been hydroxyurea. And since then, there's been for us this profusion of agents that have been approved by the FDA and EMA and so on. But hydroxyurea still, you know, around for 20 years is the one that we use, and is the most, it's the one that's available and that we have the most knowledge about, and it's by far the cheapest. So the standard criteria for using hydroxyurea, and hydroxyurea is a talk on its own. I mean, like a 1 hour talk all by itself. But the standard criteria: recurrent, severe, painful crisis, recurrent or severe, even one acute chest going to ICU. Strokes due to infarcts in the absence of chronic transfusion, so abroad they'll use chronic transfusion, and persistent symptomatic anemia. And how does it work? We don't know everything, but we know that it increases the production of F, it decreases hemolysis, it lowers the inflammatory white cells, retic count, and increases circulating nitric oxide. The other disease modifiers, L-glutamine or Endari, that's an amino acid that's normally deficient, and so the cells would absorb and use it. The mechanism is not fully understood, and we're sort of waiting for more. It's very expensive, and we're waiting for a little bit more data. The dropout rate in the study that led to its being approved was quite high, more than a third. Then the other two, actually, we were a site for the study that led to the approval of these drugs. So crizanlizumab adacteo is a humanized anti-P-selectin monoclonal antibody. So it's monthly IV infusions. Again, very expensive. When it works quite well in decreasing acute painful crisis and acute chest. Voxelotor or Oxbryta is an inhibitor of polymerization, and the hemoglobin rises, and again, you can get a decrease in painful crisis. So we're getting more experience. We're watching the literature and so on. Hydroxyurea is available. It's on the NHF. It should be offered for those indications, but there are many other indications in sickle cell disease where we will consider it, where we would say, you know what, for those things, go for it. If you have the handbook, you can put the people on hydroxyurea and call us if there's a question. But for the other indications, the kind of grayer ones, the leg ulcers and so on, the priapism, where it isn't really black and white, we would say, come talk to us. Let us talk about the individual patient and see whether it makes sense to go on to hydroxyurea at that time. All right, so we're going to do question 2. So if I could have the poll up, please. All right, here we go. So this is going to take you no time at all. So discussion with specialists is advocated when a non-specialist considers offering HU to a patient who has a history of. So I don't think you need more than 10 seconds to do that.
In that case, 10 seconds is up. No, joking. We'll give 5 more seconds.
I know it's going to be good.
And here we go.
All right, good job, good job. So we have 2/3 with Legos. So yes, the others are standard indications for hydroxyurea. All right, let's just go on straight to the next question.
Next question is up.
All right, here we go. So modifiers of the severity of the sickle cell disease phenotype include all except. So
Oh,
which one
wow.
doesn't look familiar? Yeah. You
This
were
one started off on a perfect pace.
you were listening, so I know that you're good.
5 more seconds. 4,
All right.
3, 2, 1.
Excellent. 85%. Right. That's a drug that they use in thalassemia. So as a non-hematologist, I really don't know much about it. But yes, that's that. So great job.
Do the next one, Prof.
No, not yet.
Okay.
Okay, so in this day, I can't talk to you about sickle cell without mentioning COVID. So there is a COVID registry that is trying to be global, and you can see that they've been successful in getting reports of cases from North America, South America, Europe, and even Africa. And what they have found is so far they've had 482 cases reported, which is actually up by a third in just 2 months from the last time I looked at it carefully. And what I want you to notice here is that it's slightly more female, but look at the age group, right? So it's young people. Granted, the median age of death is somewhere here. So, so that's not entirely unexpected. And as you would expect, it's mostly Black or African Americans. As you would expect, 2/3 are SS disease as against other genotypes. Because most of the cases are coming from first world countries, more than half of them were on hydroxyurea. And if we look at symptoms that they've had previously, many of them have been hospitalized for pain, have gone to the ED for pain, have had acute chest syndrome. Now, this is a really interesting slide. This is how they presented the symptoms that they had. 55% had pain. 26% had pneumonia. So pain alone, right? Pain alone as the only presenting complaint was 31%. And an additional 17% pain and pneumonia. So in people with sickle cell disease who turn up in pain, nothing else, you have to think about COVID. How are they treated? Well, most came to A&E. Some, more than half were admitted to hospital, but only about 10% had ICU admissions, and ventilation was only about 3%. And the most commonly used medication was actually heparin and then azithromycin in terms of the treatment of their COVID. There were actually some who were asymptomatic, about 15%, but most were mild. And you can see here, only 3% were critical, and we had 19 deaths. Okay, so that was about 4%. But for the most part, the symptoms resolved. And they're going to ask me, this is a topical question, should they get vaccines? That's a good question. We know that people with sickle cell disease may respond differently to vaccines. We see pneumococcal vaccine is critical. It has changed the state of sickle cell disease, but there are still a few people who don't respond to, well, back in the day where we had only pneumovax, they were still getting invasive pneumococcal disease. There would be even less now with Prevnar. But there's some individuals with sickle cell disease who actually have had recurrent episodes of pneumococcal sepsis, even with the same serotype. So their immunity may just not lead to their responding fully to the vaccine. And we've seen that also with influenza, where there was a decrease in memory after the vaccine. So they got a good response, but then the memory faded more quickly. So we're not sure, time will tell. What else can we say about COVID and sickle cell disease? Having read several papers, which I don't have time to share with you, there are some take-home lessons. There are many theoretical reasons for people with sickle cell disease to be at risk for severe COVID-19. The largest study in the US confirms increased risk compared to other people, whereas some small studies say in Europe do not. In more than one study, there's a suggestion that hemoglobin SC might be at higher risk for severe disease. And this would not surprise us because we know that for dengue, if you have dengue, having sickle cell disease puts you at risk of dying. But if you have sickle cell disease and dengue, having SC puts you at greater risk of dying than SS, which is one of those few things that are like that. If you have chronic complications and if you're older, you're also at more risk of dying. From the papers, we saw that if there was HU, there was less severe disease or chronic transfusion, that people who had crowding, which led to more exposure, were more at risk. And there may be some impact of the phenotype. But it doesn't matter. It's COVID. So masks, hand hygiene, physical distancing are critical. We've been doing virtual care. We've been doing a lot of our visits by phone. And then when numbers are down, we bring people in, see them, because we have to see them. We can't do phone visits forever. But we've been sort of having a blended approach. But remember, the usual presentations of sickle cell disease, painful crisis and acute chest, may be presentations of COVID. So what about Jamaica? As we know about 9 people so far, of whom 2 have died. But we're pretty sure that more people have had COVID than we know about. And so we're actually mounting a registry where we're inviting all of our colleagues to actually send in cases that they're aware of so that we can understand the epidemiology of COVID and sickle cell disease locally. And we would share this with the regional Caribbean registry and then into the global registry. So I'll put the link in the chat after the talk so that y'all can also send in your cases. And if you have questions, then you can talk to Dr. King. All right, now we'll have question 4. So this will be the last question. All right, which of the following is true about patients with sickle cell disease who have COVID?
Can I answer?
I know that you can because you've been listening.
All right, so 10 seconds.
All right, let's see.
All right, here we go. And the results are in.
All right, pretty good, almost 90%. Excellent, excellent, excellent. All right, okay, I'm gonna motor through the rest now. I can't do this talk without telling you guys about the Sickle Cell Technical Working Group because you may not be aware. It is an amazing thing. It is a CMO mandated committee led by the ministry, which includes the National Public Health Lab, the unit, the trust, and the support foundation, which is our patient group. There are very few committees like this globally that actually work so well. We've been doing, we've been active, and we now have newborn screening in all hospitals. Just last year, a couple of private hospitals came on board, and even some of the home deliveries were able to capture. Sickle cell disease from 2015 on the NHF list. We're doing training of healthcare workers like today, public education, advocacy. It's a very active group with subgroups, and really we're trying to change, improve the lives of people living with sickle cell disease. Something else I have to talk to you about, steady state. When a patient is at steady state, they've had no recent crises, infection, inflammatory, nothing. No treatment of an acute episode with antibiotics, no admission in the next 2 days. So if you think they're at steady state and you do it and they get admitted in the next 2 days, that is not steady state. And no transfusion for 4 months. You do their measurements then, this is their steady state. This is a very important concept in sickle cell disease. It's not just a CBC. It's also their renal function, their oxygen saturation, and whether or not their liver and spleen are palpable and what are the measurements. And why is this important? Because if they come in respiratory distress and the oxygen saturation is 88%, what does that mean? What does it mean? Well, if they always have an oxygen saturation of 88% because of the shift of the oxygen dissociation curve, you don't have to get excited. But if they are always at 97 and today they come in at 88, that's a big deal. Similarly, they come in and you feel this spleen and it's 3 centimeters. What does that mean? You have to know the steady state. If they have a little splenomegaly or you're watching them for chronic hypersplenism and it's always 3 centimeters, no problem. But if every other time it's been 0 and now it's 3, that's acute splenic sequestration. You do a CBC, you may have to admit, and if it's a second time, out goes the spleen. So it's important to know. They look pale. I don't know why I have it twice. I guess it's because it's so important. These things are very important to be able to understand an acute episode. You have to have this for reference. And then finally, as my time winds down, sickle cell disease is variable and unpredictable. Prepare to be surprised. You will have 2 siblings with sickle cell disease. One is really sick, one is hardly sick, and this one might die before that one. Prepare to be surprised. I mean, our nurse of blessed memory, you wouldn't know she had sickle cell disease. She did the work of 3 nurses, and then she caught, dengue at work, and 10 days later she was dead. Prepare to be surprised. Somebody that you think has terrible disease might live to a ripe old age. The other day, we've had patients up into their 90s. So prepare to be surprised. The complications are different from patient to patient, and they change over time in the same patient. It's genetic, yes it is, but it's actually a chronic non-communicable disease. And so you treat it as that. You use a chronic care model, physical, psychological, social, spiritual. You look at the whole person. In terms of the pathophysiology, always have in the back of your head that this is a chronic inflammatory disease. Honestly, it's a cousin of diabetes. Same kind of thing. This chronic, relentless vasculitis going on with inflammation, and then you have the acute events on top of that. An important thing is that almost every symptom, apart from straightforward bone pain, that they say is bone pain, almost every symptom that a person with sickle cell disease has could be due to sickle cell disease or something else. So we diagnose collagen vascular, acute rheumatic fever, acute appendicitis. You have to think about it. That may not actually be abdominal painful crisis. When you take the history, they're nauseous and they're anorexic, and when you examine that right lower quadrant, it is appendicitis. It can be worms. It can be anything else that other people have. Just because you have sickle cell disease doesn't mean you cannot have other things. And then this is really important, and this is part of the reason why I'm here today. One of the most important things for somebody with sickle cell disease is to have a medical home. And this is where our general practitioners come in, because not everybody is going to come to the sickle cell unit. Not everybody is going to go to the health center. It's really important that you have a medical home where people understand sickle cell disease and go through the anticipatory guidance at each step of the way, pick up the complications quickly, give the information that is necessary, and so on. We are always happy to co-manage with people. We co-manage with people in various places, locally and regionally. You have the handbook, you can access one, and you can use that to guide the clinical care guidelines. But being a medical home is what GPs do. That's what you're great at. So what we want to do is to, make sure that you feel confident and competent to be a medical home for people with sickle cell disease that are where you are as well. So this is our model for success. Everybody on deck. And I want to invite you, clearly 1 hour, I kind of just pick and choose some things to do, but we're actually having a Ministry of Health and Wellness Sickle Cell Unit workshop coming up, Demystifying Sickle Cell Management, where we'll actually spend 2 4-hour sessions talking about sickle cell disease. So there will be a whole session on lab diagnosis, health maintenance, pregnancy, chronic common complications, hydroxyurea, and so on. So that is it. I will also put those in those links in the chat. Thank you. So now I think I will have time to take a few questions.
Over to you, Dr. Buckland.
Thank you so much. That is just phenomenal presentation, and you've opened our eyes to the world of sickle cell disease and what we need to do, our role. I have several questions in the question and answer section. Dr. Tana Ricketts Rooms asks, where can PCV23 be had or obtained for purchase? That's the vaccine.
Okay. So it's available at health centers. It comes in through the National Health Fund and so on. So it is available free. I'm not sure whether they also make it available for purchase for private practice. I will ask Dr. King to let me know, and I will let you know. But it is available free of cost. HIV, Downs, and sickle cell disease are 3 diseases where you can go to the health center and get the full 4 for free.
Okay.
All
right, the next question, thank you.
Yes, go ahead, please.
We have this question here. Are there any special recommendations for analgesia during the menstrual cycle for these patients?
Okay, so you use the same approach if you have most patients with sickle cell disease will tend to be on NSAIDs for pain. If they are older and they have renal failure, then clearly we're not going to think about NSAIDs. But otherwise, it's sort of the same approach to dysmenorrhea as you would otherwise. If they have a regular cycle, which not all of our women do, but if they have a regular cycle, they know when they ovulate, they will know when their periods will start, and they can start NSAIDs like the day before to try to head off the dysmenorrhea. But otherwise, it would be the usual sorts of treatment.
Okay. Next question. Has COVID-19 in sickle cell Hbss pregnant mothers led to an increase in ICU admissions? And what are the likely complications associated with these admissions?
Okay.
Or non-ICU?
NICU. So not in our experience, and so far the infants don't really seem to be commonly affected. They've been testing them. The problem that it led to was at first we weren't doing newborn screening because those deliveries were being done away in an isolated place with no paper there and so on and so on. And so they were not getting screened for sickle cell disease. So we've been working with the ministry and the regions to put screening in place. But as of yet, we haven't seen that problem in terms of NICU admissions.
I see. For an adult patient in a rural health center who we cannot easily refer to the sickle cell unit, what recommendations regarding vaccines would you recommend?
Okay, so I'm just going to put back up our vaccine. Let me just share the screen. I'm going to go down to the vaccines. So we can just look at that again together. I need to just move this so I can see what I'm doing. All right, so here we go. Oh, sorry, I just put up the one for, okay, so they do need to get Pneumovax again in the elderly age. We do give another Pneumovax. Now, that you don't have to get from the sickle cell unit. In fact, all the vaccines for people with sickle cell disease can be accessed through the Ministry of Health, who make them available. So it is not necessary. It used to be necessary to come to the sickle cell unit for pneumovax. That is no longer so for any age group. The vaccines can be accessed through the Ministry of Health.
Okay, thank you. Can you review the interpretation of white blood cells in patients? Are labs giving a true reading, or do we need corrected counts still?
Okay.
What would you consider a normal WBC reading?
Okay, so in many people with sickle cell disease, when you say normal, the steady state is high. The true steady state is high. Okay, so in the 20s and so on. But when a child is sick or an adult is sick and you do a CBC and you're looking for your left shift, the issue is that nucleated red blood cells will be counted as white blood cells. And so you will get a falsely elevated white blood cell count. So in that setting, it is important to actually have a film or a differential to make sure that you are separating out the nucleated red blood cells from the true white blood cells so you can see what has happened. But in terms, even when you do that, even then at steady state, some people with sickle cell disease are going to have higher white counts, and that is just because of their chronic level of inflammation.
Okay, thank you. Can we have Hbss vaccination schedule distributed island-wide to both hospital and general practitioners so we can be reminded of it?
Actually, we've sent it to the Ministry of Health through the Sickle Cell Technical Working Group, and I think Dr. Lord from Family Health is working on that. She was going to get them laminated or whatever and send them out. But thank you for that question. That is something that we want to do and that we're working on actively.
So you get back in touch with us on that then?
Yes. So perhaps if whoever that, my email is a standard UMONA, jennifer.nightmadden@umona.edu.gm. Just drop me an email to remind me, and I will forward it to Dr. Lord so that we can be in touch as to how that can be distributed.
Okay, I think we have time for one more question. Sorry.
Okay, can I just say that in the public service, you should, at each institution, have access to the sickle cell clinical care guidelines because the ministry has bought many of them. I mean, a few hundred. And so there's supposed to be one at least in each hospital and health center. So you can access that as well.
Okay, the last question. I have a 35-year-old female patient who had pain, and I found that she is SS hitherto undiagnosed, but she has a high HbF. I referred her to the UHWI sickle cell unit. She's only in very occasional pain. How much does her HbF protect her? She's in her late 40s now.
Quite a bit. I mean, when we give hydroxyurea, we're trying to get the F up into the 20s and so on. And what it happens is that the F, if you think of the sickle erythrocyte, where you have the clumping of the hemoglobin S, the F kind of gets in between and stops that clumping. And so that's the start of all the pathophysiology. And so a high F actually can make quite a big difference. And remember, in people who have hereditary persistence of fetal hemoglobin, they actually don't have any symptoms.
Okay, thank you so much.
All right, thank you so much. Professor Knight, if you do have the time in the Q&A, the questions that are there, I think there are about 9 left. If you just click on type answer beside them, you'll be able to reply to each person with an answer.
Sure, I will do that. Thank you very much. And I will put those links in the chat that I had mentioned.
Perfect.
Okay, that was an excellent presentation, and participants, you did a great job in posing those questions. Our next speaker will be presenting on determining the causes and management of anemia. It's a very big area. She is Dr. Rochelle Roman, who obtained her DM at the University of the West Indies. She has practiced at the Kingston Public Hospital and the National Blood Transfusion Service. She's a past associate lecturer at the University of the West Indies, past medical director of Central Medical Labs and currently is the lab director of the Medical Associates Hospital Lab. Also, her place of private practice is at the Meridian Medical Specialist on Phoenix Central. So please help me to welcome Dr. Rochelle Roman as she presents on determining the causes and management of anemia in adults.
Thank you very much for having me. I am attempting to share my screen.
That's perfect. We're seeing your screen.
Okay, great.
Yep, it's full screen now.
Okay, great. So thanks again. I will be presenting on determining the cause and management of anemia in the adult patient. Anemia is a global public health problem affecting both developed and developing countries, resulting in major consequences for human health, social, and economic development. Anemia occurs at all stages of life, but is much more prevalent in pregnant women and in young children. In 2019, the WHO estimated that globally, 1.74 billion people, which represents approximately 22.8% of the population, are anemic. Of these, 42% are children less than 5 years of age, and approximately 40% of patients are pregnant women. Anemia is responsible for approximately 58.6 million years lived with disability. The regions with the highest burden were Western Sub-Saharan Africa, South Asia, Central Sub-Saharan Africa. The top 3 contributing causes globally were found to be dietary iron deficiency, vitamin A deficiency, and beta thalassemia trait, respectively. This picture shows the public health significance for anemia for each country, with Jamaica being severely impacted. This picture shows the public health significance of anemia. Sorry. This table shows the local prevalence among women of reproductive age, as well as for children under the age of 5. The figures have slightly decreased over the years, however, still remain significant, and we can see it's approximately 22.5% in 2016 and approximately 27.69% for children under 5 years in 2016. Anemia can be defined as a reduction in the absolute number of circulating red blood cells. From a laboratory point of view, anemia is defined as a reduction in either the hemoglobin concentration, the hematocrit or PCV, or the red blood cell count. Anemia is considered to exist when there is a hemoglobin concentration that is more than 2 standard deviations below the mean of what is considered normal. Herein lies the problem, however, because many authors propose different normal ranges for hemoglobin, and there is therefore no uniformly accepted definition of anemia. In Western populations, anemia is considered to be present when the hemoglobin level is less than 13 grams per deciliter in males and 11.5 grams per deciliter in females. Based on data from the CDC's National Health and Nutrition Examination Survey, anemia is defined as a hemoglobin of less than 12.9 for Black males and 11.5 for Black females. It is important to remember these guidelines in approaching anemia. 1, anemia is a sign of an underlying condition and not a complete diagnosis in itself. 2, it's very easy to treat deficiency anemias with either iron, folate, or B12, and therefore empirical therapy or self-treatment is very tempting. However, doing so can lead to significant diagnostic errors. The appropriate management of anemia is based on clinical evaluation combined with a systematic approach to diagnosis and treatment. The basic mechanisms of anemia can be summarized as either occurring as a result of the impaired ability of the bone marrow to produce sufficient numbers of red blood cells, or the accelerated destruction or loss of red blood cells, or a combination of both. The evaluation of the red blood cell indices is an integral part in determining the cause of anemia. These indices describe the size of the red blood cell, which is a mean corpuscular volume, or MCV, the shape and hemoglobin content of the red blood cells, which is the mean corpuscular hemoglobin, or MCH, as well as the uniformity of the red blood cell population, which is the red cell distribution width, or RDW. The mean cell volume is a measure of the average red blood cell size and is one of the most important of the indices. It is used to classify anemias and thus determine further investigation and management. This table shows the causes of anemia based on the MCV being either low, high, or normal. It also shows an estimated frequency of the causes. For the microcytic anemias, which is a low MCV, iron deficiency can be seen as one of the more common causes, occurring in about 20% of cases. Of course, this is population dependent. These figures were taken from a study done in the in the UK, sorry. Anemia of chronic disorders, approximately 20 to 30% of times as a cause of a low MCV, thalassemias, and rare causes such as sideroblastic anemias and lead poisoning. For the macrocytic anemias, these are characterized by a high MCV, alcohol abuse, vitamin B12 or folate deficiencies, unexplained causes are some of the more common reasons, certain drugs, hemolysis, liver disease, or myelodysplasia. For the normocytic anemias, which are characterized by a normal MCV, some of the causes include anemia of renal failure, acute blood loss, and others which I will go into. So let us look at the microcytic anemias. Anemia in this form arises from impaired hemoglobin synthesis. Because hemoglobin production is reduced, the red blood cells appear smaller or microcytic, that is, they have a low MCV, and they appear pale or hypochromic, that is, they have a low MCH. The hemoglobin molecule is actually composed of 3 components: iron, heme, as well as the globin chain. So reductions in any of the 3 components, for example, reduction in iron availability, reduction in heme synthesis, or reduction in globin synthesis, may result in the microcytic anemia. Iron deficiency is the commonest cause worldwide for the reduced iron availability of the microcytic anemias. And The anemia of chronic disorders, as I mentioned, is another common cause for microcytic anemias. Anemia of chronic disorders can be seen in chronic infections, inflammatory diseases, or malignancy. And they may result from impaired utilization of available iron or reduced responsiveness to erythropoietin. Paradoxically, in many of these conditions, serum ferritin, which is how iron is stored, is increased. Reduced heme synthesis may be caused by lead poisoning or the sideroblastic anemias, both of which are uncommon causes for anemia. Disorders of impaired globin synthesis occurs in the thalassemias. And in the homozygous forms, these may result in serious transfusion-dependent congenital anemia in the majority of cases. The macrocytic anemias, on the other hand, have a high MCV, meaning the cells are larger than normal red blood cells, and can be classified as megaloblastic or non-megaloblastic based on bone marrow appearances. Megaloblastic anemias result from abnormalities in DNA synthesis, and the main causes are vitamin B12 or folate deficiency, myelodysplastic syndrome, or aplastic anemia. Non-megaloblastic causes include alcoholism, liver disease, pregnancy, hypothyroidism, and drug-induced causes, for example, patients who are being treated with antiretroviral therapies. For the normocytic anemias, this may be as a result of a number of causes. The most important cause of acute onset normocytic anemia is acute blood loss. Additional possible mechanisms that result in impaired red blood cell production includes erythropoietin deficiency, reduced responsiveness to erythropoietin, or deficiency of bone marrow stem cells. In terms of the causes for the normocytic anemias, there may be overlapping causes with other types of anemias. For example, persons with early iron deficiency may actually have a normocytic picture. Persons who have chronic anemias may have a normocytic picture as well, in addition to a microcytic picture. Persons who have aplastic anemia, for example, may also have a normocytic appearance. Another important big group of anemias is the hemolytic anemias. These anemias result from increased red cell destruction, and so the lifespan of the circulating red blood cells are reduced. Because of this, the picture may be microcytic if there is significant breakdown of the red blood cells, making the average size appear small. They may be macrocytic if there is marked bone marrow compensation with large immature red cell precursors, or they may be normocytic, if there are similar amounts of small and large red blood cells. The hemolytic anemias represent a potentially dangerous form of anemia, and if the rate of destruction of the red cells exceed the ability of the bone marrow to compensate, worsening and sometimes life-threatening anemias may ensue. In the hemolytic anemias, bilirubin is variably increased due to the increased breakdown of hemoglobin. The hemolytic anemias may be due to factors that are intrinsic to the red blood cell or due to abnormalities that are extrinsic to the red blood cell. Some examples of intrinsic red blood cell defects includes the hemoglobinopathies, for example, sickle cell disease or thalassemias, red blood cell membrane defects, such as occurs in hereditary spherocytosis, or red blood cell enzyme deficiencies, for example, in G6PD. Hemolytic anemias due to extrinsic factors include the autoimmune hemolytic anemias and hypersplenism. I also wanted to mention the pseudoanemias, which occur as a result of an increase in plasma volume, which reduces the hemoglobin concentration, packed cell volume, and red blood cell count without any significant decrease in the total red blood cell mass. And one example of the dilutional or pseudoanemia is that seen with pregnancy, which is a physiologic cause. Now, in terms of the clinical manifestations of anemia, we have to remember that specific signs and symptoms may vary widely, even in patients with the same degree of anemia. Key factors that influence the development of symptoms, however, includes the degree of anemia, the rapidity of its onset, and so anemia that is slow to develop or long-standing anemia can be asymptomatic as a result of compensatory mechanisms that may limit the symptoms, and the presence of comorbidities, for example, cardiac failure, which may actually worsen the patient's symptoms. If we are to utilize a stepwise approach to the clinical evaluation of anemia, step one would be to first establish the presence of anemia, which, as we said, is when the hemoglobin, packed cell volume, or red cell mass is reduced. And again, in terms of our local perspective, we tend to consider male patients to be anemic if their hemoglobin level is less than 13 grams per deciliter, and for females if their hemoglobin is less than 11.5 grams per deciliter. Step two would be to repeat the CBC and indices to confirm that the results are obviously not spurious. After repeating, if the person is indeed anemic, then second-line tests would include the blood film, looking for other clues, for example, the presence of sickle cells, the presence of increased nucleated red cells. We look for reticulocytosis, which basically tells us that the bone marrow is compensating for the anemia. It may also tell us that this patient may be hemolyzing, and that's why there are so many immature precursors being made. We would also measure the serum ferritin, B12, and folate levels to give us an idea of whether this is a nutritional anemia. We would look at the urea and creatinine to give us an idea of whether this is renal. We would also look at liver function tests and CRP to determine if this is likely a chronic anemia. Then there's a clinical history and examination, which should include a drug history, a family history, and a social history. Specific important components to the history in the setting of anemia includes, in the history of presenting complaints, whether there is a past anemia history. If so, if the anemia is recent, subacute, or lifelong. Recent anemias, one would think that it would more than likely be as a result of something that's acquired, as opposed to lifelong anemias are likely to be inherited. In the past medical history, we should determine whether there is a history of loss of appetite, weight loss, fever, night sweats, or the presence of lymph nodes, which may indicate the presence of an underlying infection or malignancy. We need to elicit whether there is blood loss or if there is current active bleeding, whether the patient has tarry stools, if there is a history of rheumatoid arthritis or renal failure, if the patient has ever been the recipient of a blood transfusion, if there's any history of liver disease, iron therapy in the past, or exposure to toxic chemicals. In the drug history, it's also very important. We could ask questions such as whether the patient consumes a large amount of alcohol, whether the patient takes aspirin or non-steroidal anti-inflammatories regularly, which may indicate that there may be gastrointestinal bleeding. For the family history and social history, assessment of the patient's nutritional status would give us lots of information as to the possible cause of a nutritional anemia. Whether there's a family history of anemia, that could also alert us to the presence that the patient may have, say, a sickle cell or hereditary liptocytosis, one of the inherited anemias. And the ethnicity and country of origin may also be helpful because, as we know, the thalassemias, for example, are more common in certain parts of the world. The review of systems is actually aimed at determining the cause and assessing the severity of anemia. For the acute onset anemias, patients may complain of fatigue, generalized weakness, loss of stamina, acute dyspnea, syncope. For the chronic anemias, patients may complain of weakness as well, fatigue, lethargy, palpitations, shortness of breath or orthopnea, orthostatic lightheadedness, new onset or worsening of angina, new onset or worsening of claudication. In terms of physical signs, pallor of the skin and mucosal surfaces may be present. There may be resting tachycardia. The patient may have a systolic ejection flow murmur. Specific to certain causes, if the patient has B12 deficiency, they may have glossitis. They may have signs of a peripheral neuropathy. They may have a combination of motor and sensory deficits. For the hemolytic anemias, the patients may have jaundice, splenomegaly. There may be evidence of a past splenectomy or cholecystectomy. The patient may have leg ulcers or shortened digits, as seen in some patients with sickle cell disease. For iron deficiency, there may be angular chelosis, glossitis, or koilonychia. Life-threatening symptoms or signs of heart failure, angina, myocardial infarction may include hypovolemia, postural dizziness, lethargy, hypotension, and shock. Chest pains as well may also indicate a life-threatening condition. Other physical findings include the presence of lymphadenopathy or hepatosplenomegaly, which may alert us to the presence of a hematological condition. There may be bone tenderness, especially over the sternum, which may signify expansion of the marrow space. And we should actually look for other signs of hematologic abnormalities, such as petechiae, ecchymosis, and other signs of bleeding. So going back to our stepwise approach, following the clinical evaluation comes the performance of the CBC and the blood film review. Again, one of the most important tools in establishing the differential diagnosis of anemia is the MCV. So after doing the MCV, if the MCV is low, which is most commonly the case, then we should do secondary investigations, which it would include assessing iron stores and measuring the serum ferritin. Again, the most common cause for the low MCV is iron deficiency. And with iron deficiency, the iron investigations will typically reveal a serum ferritin that is low, total ion binding capacity, or TIBC, which is high, a saturation, which is low, and a serum ferritin, which is low. Other differentials for the low MCV would be the thalassemia, in which case the secondary investigations would include the hemoglobin electrophoresis and the hemoglobin A2 and F quantification. As the other differential for the low MCV, as we mentioned, the anemia of chronic disease, the patient may have signs of inflammation. They may have a raised ESR or an elevated C-reactive protein. And in terms of secondary investigations, the iron studies, they're quite useful. And for the chronic anemias, we tend to see a low serum iron, a low TIBC, which is actually one of the distinguishing features of chronic anemia versus iron deficiency. We see where the TIBC tends to be high in iron deficiency as opposed to low in the anemia of chronic disorders. The saturation is generally low in the anemia of chronic disorders, and the ferritin tends to be normal or high, which is another distinguishing feature between the anemia of chronic diseases as opposed to iron deficiency, where the ferritin tends to be low. For the patients who have a normal MCV, that is, they have a normochromic anemia, secondary investigations would include a reticulocyte count, which, if high, we should think about the presence of hemolysis or bleeding. And for patients with either, the bilirubin level, especially the indirect component, tends to be high. For patients with a low reticulocyte count, we should consider the presence of renal failure, bone marrow diseases, chronic diseases sometimes, or early iron deficiency. For patients who have an elevated MCV, secondary investigations would include determining the vitamin B12 and folate levels, checking for thyroid function and liver function tests, doing the reticulocyte count as well may give us clues as to the cause for the macrocytic anemia. The blood film evaluation will give clues as to any indication for a bone marrow. For example, if on the blood film we're seeing evidence of blast cells, that may indicate the presence of a leukemia. If we're seeing the presence of teardrop cells, that may indicate bone marrow infiltration. If we're seeing left-shifted white blood cells or new white blood cell bands, this may also suggest that the patient has bone marrow infiltration, and so a bone marrow test would be required. Once the appropriate diagnosis has been made, then we would plan further investigations and start treatment. And of course, those investigations would depend on the cause that's found. For example, for a patient who's iron deficient, we would then want to establish whether it's due to blood loss or due to diet. The patient may need to be referred to the gastroenterologist for further evaluation. Once iron deficiency is diagnosed, therapy should begin. And some of the general principles of iron replacement therapy includes: one, that iron is best absorbed from the duodenum or proximal jejunum, and therefore enteric-coated or sustained release preparations are an inefficient source of iron because oftentimes they go past the proximal jejunum before they're released. There are a number of factors that may impair absorption, including certain dietary factors such as phosphates, phytates, and tannates found in cereals, tea, coffee, eggs, or milk, to name a couple examples. Antacids, H2 blockers, proton pump inhibitors, calcium-containing foods, and certain antibiotics are some of the things that can also impair the absorption of iron. Because of these factors that can impair absorption, we should actually give iron 1 to 2 hours before or 2 to 4 hours after meals. The recommended dose for oral iron is 100 to 200 milligrams of elemental iron daily, which is, for example, 200 milligrams twice a day or 3 times a day of ferrous sulfate. As mentioned before, because of the things that can impair absorption, iron should be taken on an empty stomach with a glass of water or unsweetened orange juice. We should avoid simultaneous administration of other medications, for example, antacids, because of the increased risk of impairing absorption. Ascorbic acid, typically in a dose of 500 milligrams daily, has been found to increase iron absorption. For patients who have nausea or epigastric discomfort, we should prescribe preparations with lower iron content, as that may alleviate their symptoms. For dietary advice, we can advise the patient that they may start with small doses of iron and then increase incrementally, as this may avoid initial intolerance. We may also advise a patient that they may take iron with a meal. Yes, I know that this may decrease absorption, but it may actually lessen the gastrointestinal side effects. Concerns have been raised whether there is a role for oral iron in altering colonic microflora as well as in pathogenesis. However, no clinically significant association has been demonstrated. Parental iron therapy should be considered if the patient has poor oral iron tolerance or is non-compliant. It should also be considered if there is impaired gastrointestinal absorption, if the patient is on hemodialysis, if the patient has functional iron deficiency, as occurs in some patients with chronic anemias, or if the patient is expected to have major surgery in less than 8 weeks. With respect to blood transfusion, transfusion should only be considered in cases of massive hemorrhage, imminent cardiac compromise, or severe symptoms. So what is the expected response to oral iron? The expected response is that there should be a reticulocyte response by about day 5 to day 10. The hemoglobin is usually expected to rise by approximately 2 grams per deciliter in 3 weeks. In most cases, the hemoglobin deficit should be halved by about 1 month after commencing iron replacement, and the hemoglobin levels should return to normal by 6 to 8 weeks. In terms of monitoring the response to iron therapy, we should repeat the CBC after 4 weeks of treatment. If an improvement in hemoglobin is seen, then replacement should be continued for another 2 to 4 months with rechecking the hemoglobin. If by then the hemoglobin normalizes, iron therapy should be continued for approximately 3 months to replace stores, providing there is no ongoing cause for continued blood loss. If there's no improvement, however, at that time, we can consider switching to a parental iron preparation. There are a number of iron salts available on the market. For example, iron fumarate, sulfate, and gluconate. And these iron preparations basically have varying concentrations of elemental iron, where we can see that iron fumarate contains the highest concentration of elemental iron, and it is also the most expensive type of iron. A number of examples I've put here, such as HB Vortex, HB+, as examples of iron fumarate, ferrous sulfate, Hemafed, Sorbifor, as examples of ferrous sulfate. None have been shown to work better than the other. However, tolerability may actually be different depending on the preparation. For vitamin B12 replacement, all individuals with documented B12 deficiency should be treated. In terms of urgency of correction, most individuals present asymptomatically, and repletion can be instituted over a period of several weeks. In certain cases, it may be prudent, however, to intervene more urgently, for example, in patients who have symptomatic anemia or neurologic or neuropsychiatric findings, but pregnant patients as the fetus may be affected, or in neonates and infants as their development may be impaired. Blood transfusion should be avoided as it risks exacerbating reversible cardiac dysfunction, which can be present in the acute megaloblastic anemia. In extremely rare cases of severe deficiency, however, especially if there's hemodynamic compromise, then blood transfusion may be given carefully. In terms of route of administration, vitamin B12 may be given orally or parenterally. A number of parenteral formulations are available, including for intramuscular use or deep subcutaneous use, sublingual, and nasal administration. For symptomatic patients, initial parenteral administration is suggested in severe symptomatic anemia or in patients who have neurological findings, bearing in mind that after the patient's symptoms resolve, we can always switch them to oral therapy. For persons with impaired absorption, parenteral replacement is oftentimes used, for example, in patients who have pernicious anemia or an intestinal blind loop. High doses of oral or sublingual B12 can also be effective if given at high enough doses that actually bypass the normal intrinsic factor associated mechanism of absorption. For example, if given at doses of between 1,000 to 2,000 micrograms daily. For dietary deficiency, oral replacement is appropriate. In terms of duration of therapy, the duration would depend on whether the initial cause of the deficiency persists. In terms of whether there are any adverse effects, we should remember that vitamin B12 is a water-soluble vitamin, and therefore, even if given at extremely high doses, the majority of it will be excreted in the urine. There may be rare cases of hypersensitivity. However, serious adverse effects have not been observed. There has been associations reported between the use of high folic acid intake and cancer risk, as well as with preconception folate supplementation of greater than 1 milligram per day and incidence of developmental delay in newborns. However, no causative association has been seen. The expected response to correction of vitamin B12 and/or folate deficiency is that reticulocytosis generally occurs over 1 to 2 weeks, with resolution of anemia in approximately 4 to 8 weeks. For folate replacement, tends to be a little bit similar to B12. It's usually treated with oral doses of folate. However, intravenous and subcutaneous formulations are available. Absorption occurs through the small intestine, and the usual dose for replacement is 5 milligrams daily. Replenishment of folate stores can be achieved within several weeks of oral therapy. Maintenance therapy is not indicated except with long-term hemodialysis and in patients who have chronic hemolytic states. For patients taking medications that may alter absorption, such as the oral contraceptive pill and phenytoin, they may require supplementation of 1 milligram per day if they develop folate deficiency. An important point to remember is that we have to ensure that vitamin B12 levels are normal, or we have to replace them if they're low prior to initiating folate replacement. And this is to avoid development of subacute degeneration of the cord. So for patients with symptomatic anemia, they tend to require individual management. And of course, this management depends upon several factors. For example, the functional status of the patient, whether there are any comorbidities present, and of course, the patient's desires. There is no single threshold at which treatment should be initiated. And for some, a hemoglobin of 6 to 8 grams per deciliter may be well tolerated, whereas patients who have cardiopulmonary or renal disease may actually require intervention at higher hemoglobin levels. Currently, the main treatment for symptomatic anemia is packed red cell transfusions or erythropoiesis stimulating agents. All patients should be assessed clinically when transfusion is being considered. If the patient is stable, transfusion may not be needed, even if the hemoglobin is moderately reduced. And as such, some institutions have established thresholds for transfusion, and this is just one example. So we can see, for example, for the symptomatic patient with certain conditions, for example, an MI or tachycardia, the threshold for transfusion could be as high as 10 grams per deciliter. Whereas for the ambulatory patient, for example, a patient who is undergoing cancer treatment, we may withhold transfusion unless the hemoglobin drops to 7 to 8 grams per deciliter. In terms of advances in treatment, erythropoietin, as we know, is produced in the kidneys and is essential for the terminal maturation of red blood cells. Recombinant human erythropoietin became available for clinical use in the 1990s. And erythropoietin use has had a major impact on the quality of life in patients with anemia due to chronic renal failure, cancer, and cancer treatment. Erythropoietin is now established as a standard therapy for anemia in patients on renal dialysis, as well as for patients with established chronic renal failure who are not on dialysis. Other clinical uses for erythropoietin includes for patients who are anemic due to chemotherapy, patients who are anemic due to zidovudine therapy for HIV, for some patients with symptomatic anemia from myelodysplastic syndromes, for patients who you want to try to reduce the risk of allogeneic blood transfusion who are undergoing elective surgery, in particular non-cardiac or non-vascular surgery, and of course for patients who refuse red blood cell transfusion, although this is an off-label clinical use. Erythropoietin should be used carefully according to guidelines, as unsolicited use can result in serious adverse effects such as severe uncontrolled hypertension and thrombosis. Thank you.
Dr. Buckland?
Yeah, I'm trying to, yes, I was just trying to unmute. Thank you so much.
No problem.
Well, the floor is now open to the questions, and I see that we've got rolling. The first question to you, Dr. Roman. What are your thoughts on ferric instead of ferrous iron supplementation?
I don't think I have seen a lot of data regarding its use. I mean, the absorption should be much better because that form is absorbed easier, but I haven't really seen a lot of data regarding its usage.
All right, thank you. When should parenteral iron be commenced in a sickle cell Hbss patient with persistently low Hb levels below their steady state?
I think pretty much for most patients, the indications for iron replacement therapy, in particular with parental iron, should be based on their clinical state. And so I don't think I can give you an exact hemoglobin level as opposed to whether they're symptomatic, yes or no. I mean, the question did say that the patient is not responding to oral iron. So again, I think it would just depend on their symptoms.
Okay, next question. Are the polymaltose complex iron supplements, for example, Orofo, Ferrum, examples of sustained release iron supplements?
Yes, that is certainly their intention. Again, the drawback to some of these is that the absorption may not be as great as we would want because of confounding factors. So for the most part, in terms of the choice that we make regarding which iron preparation we use is based on cost and patient tolerability. There have been studies that have not shown any advantage of one versus the other.
Okay, the next question. What is the perspective of providing supplemental iron in patients who have poor or nil bone marrow response? What's the perspective? Yes, I will. Thank you. What is the perspective of providing supplemental iron in patients who have poor or nil bone marrow response?
So the thing is this, if the patient is iron deficient and is not responding, then we have to investigate for additional causes of anemia. And with treating those, then usually there would be an improvement in the hemoglobin. For some patients who continue to have blood loss, parental iron may increase the rate of rise of hemoglobin a little bit faster. It certainly does improve stores much quicker. That may be another option in patients who don't respond. But I think the most important thing would be to determine whether additional issues are preventing the bone marrow from responding. And a common reason would be the presence of other nutritional anemias like B12 or folate deficiency.
Next question. Why would treatment with erythropoietin work in cancer patients with normal kidneys?
So for some cancer patients, the pathogenesis of anemia is as a result of a functional deficiency. And so, yes, there may be iron available, there may be erythropoietin available, but the bone marrow just doesn't respond. And so we think that with excessive stimulation, it may cause some degree of a response.
The next question here. Which company is selling parental iron such as Venofo?
Not so sure about that one. Not so sure.
If anybody knows, you can put it in the chat. Thank you. Are there any other questions?
I can always add it. I can always check and add it. I can do that.
Thank you. So as far as other questions, I do see where persons are saying congratulations for the presentations, and they're asking Dr. Roman and Professor Knight Madden if where possible to share their professional numbers and address of your practices, perhaps for referrals, etc.
Okay, certainly.
All right. I think we will all agree that we have all just participated in 2 excellent presentations on the management of sickle cell disease, presented by Professor Jennifer Knight Madden, and determining the causes of anemia in adults by Dr. Rochelle Roman. It has been a feast, a very wonderful feast. And I think we're going for the next course, which will be handled by Dr. Arna Morgan. Thank you so much to the 2 of you. You've done us proud, and so glad that you're able to come on board the Association of General Practitioners to share your extensive knowledge on these important topics. Thank you both.
You're most welcome. Thank you too.
You're very welcome. Thank you for the invitation.
You're welcome.
I think it's my time now then to say good afternoon to all participants of this seminar this evening, this afternoon. We're right on time, and it is time for me actually to ask our sponsors, Medimpex, to present for a 5-minute slot. Our presenter from Medimpex is Mrs. Paulette Bedward. Mrs. Bedward, please, it is your time.
All right, let me just see if I can get in touch with her by mobile.
I'm here.
Oh,
and
there
just
she goes. There she goes. There she goes.
unmute my and also start my video.
No problem.
And share my screen. All right, I'm off. Share screen. Sam, help me here. Share your screen. Wants to share the contents.
All right, so once you click on share screen, you should see at the top basic, advanced files, click on basic. And then at the top left, you should see screen. It should be highlighted in blue.
All right, so once I click on share screen, I'm seeing share your screen. Zoom wants to share the contents of your screen. Choose what you'd like to share. Your entire screen, application window,
entire screen.
entire screen. But share not coming up as an option for me.
You're using a Mac?
It's there. It's there.
Okay.
Perfect. Are you seeing it now? Are you seeing my screen?
Yep, definitely.
All right, awesome. Good afternoon, everyone. And thank you for having invited us to be a part of your lovely conference this afternoon. All right, so just a backdrop on who or what is Medimpex Jamaica Limited. Medimpex is a merger of two factories, Aegis and Gideon Richter. And I must say it's an Hungarian pharmaceutical company. Aegis, to bring it closer to home, they are the manufacturer of Erlin, and Gideon Richter is the manufacturer of Cleondy. So I like to put it that Erlin and Cleondy, those makers are the owners of Medimpex. Our company motto is quality products for healthy living, and we have been in Jamaica since 1978, and we remain committed to providing quality products at affordable prices. Today, I would like to focus on just about 3 of our products. The first being our Curiosin gel. What is Curiosin? Curiosin is a wound care preparation designed for quality wound healing. It is a clear, non-irritant, highly biocompatible product supplied as a gel for the management of various types of wounds. How does it work? It works in 3 ways. By providing a moist environment that is necessary to provide physiological wound healing. It also forms a viscoelastic matrix that facilitates granulation and epithelialization. And it also protects the cells from free radicals, resulting in reduced tissue inflammation and controls wound pain. And I know our first presenter this morning, Dr. Jennifer Knight-Madden, spoke about wound pain in the sickle cell patients. Indications, it's used in the management of chronic wounds of different origin. And Dr. Knight-Madden also spoke about the leg ulcers. It's also used for the management of minor injuries, such as your household injuries, your lacerations, and your first and second degree burns. So today I just want to focus on Curiosin for the treatment of your leg ulcers. And here I have a few images. So this on the left, it shows a patient suffering from leg ulcer of venous origin. that's accompanied with an eczema. And the patient is a 65-year-old male. Curiocin was used once a day, and after 9 months of treatment, there was complete epithelialization, and the underlying disease could have been identified as stasis varicose. Here we have another scenario. Leg ulcer of venous origin persisting for 20 years, and this is a female, 60-year-old. On the right, you see nearly complete healing after 9 months of treatment. All right, and here we have a patient, 38-year-old, bed sore, and here we have complete epithelialization after 2 months. And you can see the severity of the bed sore. The skin was coming off, there was maggot in the wound, and complete healing after 2 months of treatment. How is curiocin used? 1, clean the wound. Complete debridement if needed by gently rinsing with 3% hydrogen peroxide or saline. During wound healing, the affected area can become overrun with necrotic or dead tissues, and this can be harmful to the body's ability to recover and develop new skin. So debridement is necessary in preparing the wound bed to promote speedy and efficient healing. Curiocin creates a moist environment that enhances the body's natural ability to shed off dead tissue. Second, we apply curiocin as a continuous thin layer. Just a 1 millimeter film of the gel is needed, and that we apply to the entire compromised skin area once daily. Apply on and around the wound as it reduces inflammation and protects the skin around the wound. A clean application aid such as a tongue depressor or a gloved hand can be used. Lastly, cover the wound with a non-stick gauze dressing and self-adhesive bandage, and this of course is optional. You can also choose to leave the wound uncovered. NHF does cover curiocin gel, and the subsidy is $843 per tube. The patient will pay $1,100 per tube, and the allocation, it's 1 tube per month or 2 tubes if the condition is severe. What conditions is curiocin covered under? It's covered under vascular disorders as well as diabetes. The next product that I would like to focus on this afternoon is our Sorbifol. And here, this is our Sorbifol leaflet that we use in our detailing. Just to remind you, the Sorbifol, it's a slow release technology. Just to go back a bit, here we have the Sorbifol dilules, and the iron is embedded in a spongoid matrix, and the iron is gradually released over 6 to 8 hours. At the end here, you see the empty structure disintegrates and it is excreted from the body. So the patient will pass it out in their feces, nothing that they can see, so they won't be alarmed about it. So it has a slow release technology, and that ensures that the iron is properly absorbed and results in fewer side effect profile. Just to point out, it's actually 320 milligram ferrous sulfate per tablet, and it delivers 100 milligram of elemental iron per tab. So that's all of 100 milligram elemental iron. The ascorbic acid or vitamin C present is 60 milligram per tablet, and our price, very affordably priced, only $23 per tab. And also to point out, the Sorbifol is available over the counter, so your patient can just walk into the pharmacy and ask for it by name. The dosing 1 to 2 tablets daily. And as we pointed out earlier, advantages of the Sorbifol: less chance of constipation. It doesn't have any stool softener, but it doesn't need any due to the special technology that goes into making the iron. Less GI irritation, faster absorption of the iron due to the vitamin C. It's a small tablet, odorless, and it's very affordable. Right. And just to point out, Medimpex distributes for a line of vitamins called Prime Health. So I'd just like to use this forum to introduce it or reintroduce it to our physicians. So just to focus on these three, our prenatals, which is our vitamins and mineral supplement, or children gummy, and we also have iron complex for women. Right, and our iron in our Prime Health, it contains 45 milligram of iron, folate, 500 micrograms, vitamin B12, of which is 1,000 micrograms, and also contains vitamin C, 100 milligrams. Right, so this is just an overview of all the products that we carry in the Prime Health. We have the multivitamins, advanced formulation, vitamins and minerals for men, omega 369 or fish oil, and glucosamine and chondroitin. And the price is very affordable. We can see our iron complex, 60 capsules, and it's sold from us, 1,363. So for those stocking physicians, you can speak to your med rep and ask them for the Prime Health product sheet. All right, thank you very much. Thanks for your attention and enjoy the rest of your afternoon.
Thank you so very much, Mrs. Paulette Bedwood from Medimpex. We've learned quite a bit here. Your Curiosan really does look like a wonderful product, as well as sharing with us your product Sorbifol and your Prime Health vitamins. Thank you again. Well, now we come to another one of our presenters, and this person is Dr. Angela Scott, who is going to present to us this afternoon on recognizing hematological malignancies in primary care. So this is something that we probably miss until it's really gone bad. So yes, we welcome Dr. Scott. Now, Dr. Scott is not a stranger to us at all. And I must mention, of course, her very popular spouse, Dr. Paul Scott, pulmonologist, who is very, very dear to many and myself. Dr. Scott is a clinical hematologist who completed both her undergraduate and postgraduate training at the University of the West Indies, Mona. She also worked in the blood banking in Colindale, England, and she has served Jamaica medically in several substantive posts. She was the director of the National Blood Transfusion Service of Jamaica, and she later served as the director of the National Laboratory Services for 4 years between 2011 and 2017. She was a part of the team that worked towards the National Public Health Laboratory becoming an accredited institution in 2015. Dr. Scott is currently the consultant hematologist at Caledonia Biomedical Laboratories, and she has a hematology, oncology, medical practice at 1A Braemar Avenue, Kingston 10. She is an avid gardener, and she enjoys decorating and working with young people. So I'd like at this time to invite our friend and our presenter today, Dr. Angela Scott, to go ahead now with her presentation on recognizing hematological malignancies in primary care. Welcome, Dr. Scott.
Thank you, Dr. Brown. And I'd like to thank the organizers for allowing me to present today. The conference has been wonderful so far. Now, the topic, as you indicated, is recognizing hematological malignancies in primary care. My focus is going to be on the clues we can pick up when the patients are seen that will point us towards actually doing further evaluation that will lead to the diagnosis. What I will not be covering is the treatment of hematological malignancies, nor the cytogenetics related to them. So the focus today is going to be on those conditions highlighted, the acute and chronic leukemias, non-Hodgkin's lymphoma, I will mention Hodgkin's disease, and for the plasma cell dyscrasias, I will focus on multiple myeloma. And I will make brief mention of adult T-cell leukemia lymphoma because of its significance in our population. And I've put myeloproliferative disorders there because since 2008, they have been classified now as malignancies, which they were not before. Now, if we look at the overall cancer burden of the hematological malignancies, we see that they're accounting for between 8 to 10% of the malignancies that are diagnosed annually. There's some amount of underreporting with this. As I mentioned, the myeloproliferative disorders, and by that I mean things like polycythemia, essential thrombocytosis, and myelofibrosis, are all now considered malignancies, but often are not picked up readily in the registry. And also in our data on mortality, they tend to be signed out as something else. But just to say that hematological malignancies account for at least 10% of the cases of malignancies in Jamaica. Now I wanted to look at our cancer burden in terms of our hematological cancers and how we compared with, and I randomly picked 3 other countries. I used Trinidad and Tobago, the US, and the UK. And you will notice that for non-Hodgkin's lymphoma, it is our 7th most common malignancy overall. And in fact, it's number 4 in our men. But that is similar across the board. If we're looking at Trinidad and Tobago, US, and the UK, it's ranking 6th or 7th for them as well. If you look at the percentage of cancer cases, for us, non-Hodgkin's lymphoma represents 3.4% of our diagnosed cases of cancer. And in the other countries, it ranges between 3.1 to 3.7%. Again, I think reasonably comparable. For multiple myeloma, though, we seem to be a little higher in terms of the cancer burden for this disease. And my feeling in my practice, although that would be anecdotal, is that this is reliable. We are seeing quite a number of cases of multiple myeloma. So for us, multiple myeloma ranks 10th, while for the other countries, it's between 15th and 17th when you look at the diagnosis relative to other cancers. For the leukemias, and these are all banded together, whether they are acute leukemias or chronic leukemias, we're similar. The US might have a slightly higher percentage, but we're all ranging about 2.2 to 2.7% of our diagnoses are due to leukemias. For Hodgkin's disease, the incidence is far less, and I'm not going to spend a lot of time talking about that, but I will make a comparison with non-Hodgkin's lymphoma. And when we look at the mortality, again, we want to see, are we doing as well as the other countries in terms of the management of these patients? Are they dying at a higher rate, or are the statistics comparable? And when you look at non-Hodgkin's lymphoma, our mortality rate is probably a little higher than the other countries. And I think that is in part due to the fact that we have a high number of patients with adult T-cell lymphoma, which to this day remains pretty difficult to treat and is associated with a high mortality. I'll speak a little bit more about that later. Multiple myeloma being high in our incidence table will again be associated with a higher mortality than the other countries. But for the other conditions, we're comparable. For leukemias, we're doing about the same as Trinidad and Tobago and the UK. You'll remember that the US had a higher burden for leukemias than we do, and their mortality rate is also higher. And for Hodgkin's disease, we're relatively comparable. So now I'm going to look at the actual hematological malignancies in turn. I'll look at the acute leukemias first. Now, this is a classification, but the vast majority will fall into the category of acute lymphoblastic leukemia or acute myeloid leukemia. Now, the acute leukemias. And when we think of the word acute, we think of rapidly progressing, which is true. But the main thing that separates an acute leukemia from a chronic leukemia is blast cells. So the diagnosis is made based on the presence of blast cells and in particular in the bone marrow. So we might get clues from the peripheral blood film, but we're not able to make the diagnosis based on the peripheral blood film. So the diagnosis will be facilitated by an aspirate or a biopsy, which is stained, and flow cytometry will help us to further subdivide the type of acute leukemia we're dealing with. Gone are the days when we sat and looked for hours and tried to figure out if it was a myeloid cell or a lymphoid cell and so on. We now realize that for the most part, we're guessing, and we need further evaluation to really clinch the diagnosis of whether we're dealing with an acute lymphoblastic leukemia or acute myeloid leukemia. Now, who gets these conditions? For ALL, acute lymphoblastic leukemia, it can occur at any age, and it is commonest in children, and most cases are diagnosed by the age of 5 years. Males account for more cases than females, and you'll find this for almost all the hematological malignancies, that there's a male preponderance. The cure rates are highest in children, and right now their cure rates is over 90%. Most of the deaths due to ALL occur in adults. Overall, though, it is the least common leukemia. So most common in children, but overall the least common leukemia. Acute myeloid leukemia now is the commonest of all the leukemias, and the majority of patients are diagnosed after age 60, but this condition can occur at any age. Again, males more common than females. Now, acute myeloid leukemia can occur de novo, or it may follow a diagnosis of a chronic leukemia. It may follow the diagnosis of a solid tumor that has undergone leukemic change. The myeloproliferative disorders can also transform to an acute leukemia, and acute myeloid leukemia is the more common. It can follow treatment for a number of conditions. when we look at the risk factors, because we always want to see, can we do something about getting the disorder? Or is there anything we can modulate to make the risk lower? Exposure to radiation comes up for almost all hematological malignancies. And again, for both acute leukemia, certain genetic disorders have been associated. Previous cancer treatment, as I mentioned, exposure to certain chemicals, smoking, certain viruses, in particular with ALL, the EB virus, and increasing age is said to be a risk factor, as well as a history of prior blood-related cancers. And this is more so for AML than ALL. I have ATL here as well, because the risk factor for ATL will be the presence of the HTLV1 or 2 virus. Now, for the most part, the patients we are going to see will either not have an obvious risk factor or are unable to give us a history of the association with an exposure to a particular chemical or other agent. So this just represents some of the genetic syndromes that can be associated with acute leukemia. So yes, we must look for these, but as I said, the majority of our patients are going to turn up with no such history or finding. And again, the exposure to chemicals and other drugs needs to be recalled. However, when we think of things like industrial exposure and so on, the exposure may be up to 20 years or more before the onset of the leukemia. So it's difficult for the patient or the clinician to make the correlation. So how do these patients present? Now, remember, the problem with an acute leukemia is these blast cells. So we have these early premature cells that are normally in the bone marrow. They have become rogue, I want to call it that way, in the sense that the normal signal to turn off or to signal cell death has been turned off. So these blast cells are expanding in the bone marrow, and they now can in turn infiltrate other tissues. So the clinical features are related to the fact that when they expand in the bone marrow, they impact the normal production of the other cells. So the patient can become anemic, neutropenic, or thrombocytopenic. Those cells, because they can also infiltrate organs, will present with organomegaly of different sorts. The key thing I want us to remember is that the symptoms are largely non-specific. So we don't have a symptom where we say, okay, this is a symptom of a leukemia. And we're going to look at the list of symptoms in a little while, but weakness, headache, joint pain, pretty much flu-like symptoms, pretty much the everyday sort of symptoms that you see in a primary care practice. The symptoms are also usually low risk. And what do I mean by low risk? The patient is not going to come seeming in extremis. It's not a patient with a massive upper GI bleed or something that you're thinking, rush them off to hospital. It will be a little nosebleed or a little bruising, things that don't seem to need urgent attention. As a result, many cases will be a surprise to the clinician and is only suspected after the blood result has been returned. While not usually a medical emergency, in some instances, the patient may progress rapidly. So the diagnosis should be treated with some measure of urgency once it is suspected. So just listing some of the symptoms here. Again, nosebleeds and gum bleeds, easy bruising, fever, fatigue, weakness or lethargy, shortness of breath, abdominal pain, bone pain. Now, weight loss is not a common feature of acute leukemias and only accounts for 2% of cases having this particular symptom. I've tried to put in brackets some of the reasons why the patients present with some of these symptoms, but as indicated before, the symptoms are very non-specific. Somebody complaining of abdominal pain. There are just a whole host of things that would come to mind as possibilities. Before I go to that picture, it means therefore that when we're seeing patients with any of these symptoms, because they're also possible symptoms of leukemia, we should be thinking that this patient should have at least a baseline blood count. I've put the picture of gingival hyperplasia or gum hypertrophy is the other expression we use, because this patient had an absolutely normal white count because the blast went into the gum spaces. The clues, however, on the CBC was the fact that the hemoglobin and the platelet count were both low. Just wanted to share a quick case of a 3-year-old who was returning from a trip with her dad from a brief holiday overseas. During the flight back, they experienced some turbulence and she fell forward onto the seat. What her dad noticed almost instantaneously is that she developed a COCO, as he puts it, so it was a hematoma on the forehead. He felt that the impact that she had should not have led to this hematoma. And so he left the airport and went straight to see his pediatrician or the child's pediatrician. And the finding then was a platelet count of 3. Now, I put this here to say he could have ignored it and gone on. She was already in a bad state, but she was otherwise healthy and well, had no other complaints. So the evaluation as to why she had this low platelet count resulted in us finding that she had a significant amount of blasts in the bone marrow and had to be treated for acute lymphoblastic leukemia. Her treatment went through all the phases and she is well today in her 20s. Now we look at the chronic leukemias. This is a slide I looked at yesterday, and this classically shows you how the acute leukemias, you're not seeing blasts, they're just normal looking cells. And in this case, we have all these normal lymphocytes. The main issue is that the number is increased, and we're seeing some of these smear or smudge cells, which represent just breakup of the cells when the leukemic cells tend to be, especially in CLL, more fragile. So the hallmark for the chronic leukemias is going to be an increased white count. So unlike with the acute leukemia, the count in most cases is increased, but it may be normal, as indicated with that child with the gum hypertrophy, or it might be low. And sometimes it's the other cell counts that clue us into something being wrong. With the chronic leukemias, on the other hand, the white count is increased. For CLL, as we looked at the film just now, the mature lymphocytes and smear cells are usually what are seen on the slide. And sometimes we see more immature cells, but not blast. We see pro-lymphocytes. Other features represent advanced disease. So we shouldn't be waiting until we can find splenomegaly or anemia or thrombocytopenia or lymphadenopathy. Again, making the comparison with the acute leukemias, the anemia and thrombocytopenia are fairly common. But with chronic lymphocytic leukemia, all that is present early in the disease is the increased white count. And I think I'm repeating myself here, but I guess it bears repetition that early presentation for CLL, no symptoms. So these patients are often found, if it's early disease, as an incidental finding. Later in the disease is when we get the enlarged painless lymph nodes, the fatigue, the fever, the pain, upper left abdominal discomfort, and this might be because of an enlarged spleen, night sweats, weight loss, and frequent infections, though they're at the bottom, is not necessarily late. This can occur earlier. Some of the risk factors noted there, long exposure to pesticides. There is a familial tendency with CLL, unlike most of the hematological malignancies where there is no familial relationship. For CML, chronic myeloid leukemia, again, the hallmark for the chronic leukemia is an increased white count, and we're seeing left shift. So this is a sort of situation where you could find left shift because you're having fever, you're having bleeding, and so on. However, CML always has to be kept in mind, and some of the features that are going to clue you in that you might be dealing with CML rather than a leukemoid reaction is the presence of the basophils. If the basophil count is increased, it is pushing the diagnosis a little more to CML than to a leukemoid reaction, but none of these things are absolute. What is going to clinch the diagnosis is the presence of the Philadelphia chromosome. And this can be detected on a blood test or on the bone marrow. Now, even though we're not speaking about treatment, it's important to note that the survival of CML patients has improved significantly over the last decade or so because of the introduction of targeted therapy that will target the presence of the Philadelphia chromosome. For instance, Gleevec now makes the survival, the 5-year survival, much better. And the figure in 2015 was 69%, and I believe it's much better now because we have a number of other agents which block the tyrosine kinase that is produced as a result of the presence of the Philadelphia chromosome. So say 15 years ago, prior to this data, the 5-year survival was about 31%. It has jumped up, and I'm sure it's better than 69% now. Again, risk factors, certain organic chemicals. Now, both of these conditions are going to be more commonly seen with advancing age. So most of the patients are going to be over 60 years of age when they are diagnosed with a chronic leukemia. The clinical presentation, we touched on this already. Again, want to highlight that the majority of these persons will have absolutely no symptoms. So they're just going to be picked up on routine blood work or blood work done for some other reason. I want to mention here that CML is associated with the presence of chloromas in some patients, and I want to try and show you a picture of what a chloroma looks like. And I'm not sure we're actually seeing this very well, but it looks like a discolored lump, which can occur anywhere on the body. The limb is fairly common, but it can occur on the face as well. So this is one of the things that you may find on the patient, that again, it says a CBC is absolutely necessary in the workup of the patient. Now, when we look at non-Hodgkin's lymphoma and Hodgkin's disease, as indicated by the table earlier, the majority of patients who are going to fall in the lymphoma category will have non-Hodgkin's lymphoma. Hodgkin's disease is far less common in our country and in many parts of the world. The malignant cell here is the lymphocyte, and the hallmark of these diseases is going to be enlargement of the lymph nodes and the spleen, or the spleen. It can occur at any age, but the greatest risk is in the age group over 60 years. There are numerous subsets of non-Hodgkin's lymphoma, so we're not going to go into all the subsets. The essence of what we need to recognize is that a lymph node that is persisting requires a biopsy, because the diagnosis can only be made on the histology of the lymph node, or spleen if the spleen is enlarged in that particular patient. Some of the risk factors quickly. In the case of NHL, some viruses and bacteria have been implicated. The EB virus mentioned earlier, HIV, Helicobacter pylori in terms of lymphomas in the gut, chemicals, pesticides, and some of these, though they're banned in some parts of the world, they're still being produced in other parts of the world, so they still bear some significance in terms of causation. The main characteristic of NHL is going to be painless lymph node swelling. However, there are going to be a few cases where, because of the rapid growth of the lymph node, the patient has pain. So pain does not negate the possibility of a non-Hodgkin's lymphoma being the cause of the lymphadenopathy. Abdominal pain is often due to enlargement of the spleen or the liver. Patients with NHL can have involvement of the lung or the pleura. They can have effusions. And later in the course of the disease, they will have constitutional symptoms, the fever, the night sweats, the fatigue, the weight loss. If the patient has lung, liver, or bone marrow involvement, that is already stage 4 disease. So we're not trying to wait until we find these other abnormalities. We want to get to the patient earlier. So that one lymph node in the neck that is persisting needs to be biopsied so we can improve on the patient's survival or long-term progression-free survival. It's not that treating them later doesn't still have the potential for cure, but the percentage of patients that can be cured when the disease is more advanced is far less. So the physical examination for a patient with NHL or non-Hodgkin's lymphoma is going to be critical. And you're basically trying to find out if there are any other lymph node areas, any organ involvement, because these are some of the things that are going to support that this lymph node that is in the neck or wherever it was found is not benign. Because this is always the quandary we have, you know, is this a benign lymph node and I'm sending the patient to do a biopsy unnecessarily? Give it a few weeks, and if it's not getting smaller in size, then definitely the lymph node biopsy is indicated, and that is where we will get the definitive diagnosis. Rarely these patients become leukemic, and then we are able to do flow cytometry to help us to make the diagnosis. But generally speaking, the majority of patients with non-Hodgkin's lymphoma, especially in the earlier phases of disease, will not have anything on their complete blood count that will clue us in that they have a lymphoma. And looking at the comparison between non-Hodgkin's lymphoma and Hodgkin's disease, because both of these conditions really just present with the abnormal swelling of a lymph node, which is persisting. The pathognomonic finding for Hodgkin's disease is the presence of the Reed-Sternberg cell on the histological sample. So its presence tells us it's Hodgkin's disease, its absence, non-Hodgkin's lymphoma. So in other words, that's the main separating factor for these two conditions. Non-Hodgkin's lymphoma is typically in an older age group, but as indicated before, it can be any age group. So children do get NHL as well as adults. For Hodgkin's disease, tend to be a younger median age, and it tend to be around the age in the 30s. The nodal spread for non-Hodgkin's lymphoma is non-contiguous. And what I mean by that is you may find lymph nodes in the neck. Then on imaging, you have retroperitoneal lymph nodes. You might have some iliac nodes. In other words, different nodal groups occurring at the same time. For Hodgkin's, you will start with one in this cervical triangle, and then it will extend to more in the same area. It's not going to jump across the diaphragm, or it will spread locally first before going to other areas, usually. There is a slight problem with alcohol intolerance and pain in the nose that is seen with Hodgkin's disease. It's not very common, but it's one of the things that if it occurs, clues you in that you might be dealing with Hodgkin's disease. It occurs in 1 to 5%. Forgive the typo there. The stage of diagnosis, again, tends to be a little later with NHL. While for Hodgkin's disease, since the nodes are getting bigger in the same area, we are inclined to make the diagnosis earlier. But it just goes to say, if a patient has an enlarged lymph node that is persisting in a particular area, we need to image other areas to see if there are lymph nodes in other places that are not immediately obvious. Both are curable, but as the stages advance, and that should be stage 3 and 4, then the cure rate falls off drastically. Extranodal involvement is very unusual with Hodgkin's disease, but it's fairly common with non-Hodgkin's lymphoma. And extranodal involvement meaning involvement of the gastrointestinal tract, involvement of the skin, involvement of the lungs. These are some of the places that NHL can go to. And just again, reminding us of the frequency in which we see them. NHL, 4th commonest malignancy in Jamaican men, 7th commonest malignancy overall, while Hodgkin's is down at 26. Now we're going to turn our attention to multiple myeloma. Again, this was one of the conditions that I think is, we're seeing a significant disease burden, and we need to be able to identify these patients early. So here, the problem cell is the plasma cell. And again, we all have plasma cells in our bone marrow, but when the plasma cells apoptosis, or when cell death is turned off and the plasma cell is multiplying out of control, then a plasma cell malignancy is present. It often is associated with destruction of bone, and that is related to the cytokines that are released from these plasma cells. When we get to finding anemia and hypercalcemia and renal impairment, which are some of the common things we think about with multiple myeloma, the disease is already advanced. So we want to diagnose these patients earlier. Now, there are major and minor criteria for making the diagnosis, which the hematologist will use to clinch the diagnosis of whether we're dealing with multiple myeloma or another plasma cell dyscrasia or something totally different. Even NHL is a possible differential. But what we must realize in terms of early in the evaluation of the patient is the presence of either rouleau or globulins, increased globulins. So how are we going to suspect that the patient has multiple myeloma? Let's look at some of the risk factors first. All right, like most of the hematological malignancies, apart from ALL that we said is mainly in childhood, the age of diagnosis is over 60 years and the average still remains around 70 years. Only 2% of patients will be below 40 years. Part of the reason why we might have such a higher burden is because the diseases seem to be more common in Blacks than Caucasians. The reason for that is not well established. Risk factors that are from previous exposure, radiation, chemicals, we mentioned benzene, pesticides and herbicides in other hematological malignancies, the same is true here for multiple myeloma. But in addition, there are some persons in some industries that have been shown to have a higher risk. Rubber manufacturing, professional firefighters, and persons who are repeatedly exposed to wood products, example, carpenters. "95% to 97% of the patients will have an M-band when we do a serum protein electrophoresis. So the vast majority we will be able to diagnose on the serum protein electrophoresis. So we'll do the globulins first in a patient that we think is in the age group for the disease, because we're not waiting for symptoms. So this might be your routine annual executive profile that you look at what's happening to the globulins. So you monitor the trend of the globulins in these patients. If the globulins are up, then serum protein electrophoresis and urine protein electrophoresis are indicated. But we must make mention of the fact that the absence of an M-band in the serum or the urine does not exclude the diagnosis. And so there is a small percentage of patients that we have to dig a lot harder. And this is going to, often they come to our attention because the lytic bone lesions which looks suspicious for either metastatic cancer or multiple myeloma, are seen, but they're not having an embed. So the hematologist will order additional tests to try and tease this out to see whether or not we're dealing with multiple myeloma. Common ways in which the patients present include the presence of lytic bone lesions, pathological fractures, or a positive bone scan, which might have been done for other reasons. The alkaline phosphatase, even though bone disease is common in multiple myeloma, the alkaline phosphatase is not usually elevated. It's only in the patients who have a healing fracture that the alkaline phosphatase will be increased. So normal alkaline phosphatase does not, again, preclude the possibility that the patient has bone disease and significant bone disease as well. Now, like most cancers, if diagnosed early, then the survival rate is better. When I was training, the average duration for patient, average survival for patient diagnosed with multiple myeloma was about 2 years. That has significantly improved. We have a lot more active agents for myeloma, and it is turning more into a chronic disease than something that is likely to kill you acutely. However, it is important, again, that we get the patients early, because when the patients are more advanced and we're dealing with renal failure and they're needing dialysis, or the hip is totally gone and you have surgeries to do, it impacts the treatment for the underlying cause, the multiple myeloma. So there are long delays in treatment, and therefore the overall survival is impacted. But barring that, I'd want to say, irrespective of what stage, whether it's stage 1, 2, or 3, because multiple myeloma has 3 stages to the disease, there is still the possibility of a significant survival rate, which is much improved now that we have more targeted therapies than we did before. I indicated that I wanted to mention a bit about ATL, and I have here ATLL, adult T-cell leukemia lymphoma. Because this is a spectrum of diseases, and we'll look at the classification in a little while, but the reason why it's important is based on previous studies and looking at the patients from or transfusion or donors, we notice that the rate of HTLV1 seropositivity ranges between 2 to 6%. Now, only a small fraction of these patients will develop ATLL. However, the impact of the disease is significant, and it's important that we think about it when we're seeing our patients. Oops. All right, so there are 4 subtypes: acute, lymphoma, chronic, and smoldering ATL. And all require the presence of HTLV1. You might be clued in that this diagnosis exists or could exist by a comment from the hematologist or the medical technologist reading the blood film that says cleaved or flower cells seen. Sometimes I'll make a comment, do HTLV1. This will allow us to monitor the patient more closely and to determine where they fall. Is it totally asymptomatic, no problems, but we need to monitor for transforming to an acute or lymphomatous form of adult T-cell leukemia lymphoma. The male to female ratio is almost equal, still a slight, very slight difference in the number of males that were seen in the 1986 to 1995 study, but it didn't make statistical significance, so hence I put a 1-to-1 proportion. The age range is 17 to 85 years. Now, typically this condition is going to be because the patient inherited the patient acquired rather the HTLV1 from the parent. So ATL is more commonly seen in persons where there is vertical transmission of HTLV1, while TSP is more commonly seen in persons who acquired HTLV1 sexually. And hence, unlike most of the other leukemias and lymphomas and so on, the age range goes down to very early, and there's even an instance of a 13-year-old. But it also says it takes a long time for the virus to impact the white cells to the point that they become malignant. The majority of cases we see, unfortunately, are acute, followed by the lymphoma form, and both of these carry a very high mortality rate. So once this is suspected in the presence of HTLV1 seropositivity, early referral is recommended. This is just highlighting the classification, or not that we're going to try to remember all these things, but just to say, with ATL, the absolute lymphocyte count, which is in our first row, is normal. And smoldering ATL, also normal. So having a normal lymphocyte count doesn't preclude us looking at the other features of the disease. We're looking for things like presence of other organomegaly, because again, the hallmark for the lymphomatous form of ATL is going to be the presence of an abnormal lymph node swelling. And it is from the lymph node that we get the diagnosis from the positive histology. With acute ATL, on the other hand, the white count is increased and the abnormal lymphocytes in the blood are also increased. And then we can use other methods to make this diagnosis, including flow cytometry. But none of these, whether they're smoldering, chronic, lymphomatous, or acute, should be ignored. All patients with HTLV1 seropositivity should be followed fairly closely and advised as to some of the things they should look for and return for medical attention if seen. For instance, enlargement of the lymph nodes, enlargement of the spleen or the liver, and signs of and symptoms related to hypercalcemia. Unfortunately for acute ATL, a lot of them present to us in extremis. So they're often, they have signs of hypercalcemia, and there is rapid decline in these patients. Again, the prognosis is improved only slightly with early presentation, because unlike the other hematological disorders that we have just looked at, with ATL, we still haven't been able to establish cure in the majority of patients. So most patients with ATL, whether it be leukemic form or lymphomatous form, the outcome is poor. But there's a lot of work going on in the US, in Japan, looking at additional drugs which are prolonging the lives of these patients and improving the outcome. And we're hoping that ATL will see the improvement that conditions like CML and multiple myeloma have seen. Quick word about the myeloproliferative disorders.
Doc, just to say we have 1 minute left.
Right, this is the end. All right, well, just to say that these have become malignancies since 2008. So when I was training, these were not considered malignancies. The hallmark of these disorders is going to be high hemoglobins, white counts, or platelet counts. So these persons should be referred to be able to distinguish between a reactive cause and a malignant cause. I think I highlighted my take-home points as I was going along, so I will wrap up at this point and allow for questions. Oh, one quick statement. I wanted to again highlight the issue that a lot of patients coming with hematological malignancies will not have weight loss as a prominent feature. This is a patient of mine who I took this picture this week. He has advanced multiple myeloma, but no issue with weight loss, as is the case for many of the patients. And thank you for listening.
Thank you so very much, Dr. Scott, for bringing to us so much information and on these various forms of blood cancers and the differences between acute and chronic diseases and how to differentiate them. We're going to ask Sam to direct the questions to you at this time. Thank you so much for a very excellent presentation.
Thank you so much, Doctor. So the first question is from Dr. Plaza. What's the minimal diameter to submit one lymph node to biopsy in adults?
Well, that's a hard question, but usually when the lymph node is a centimeter in diameter, then we'd consider it definitely significant. But it doesn't mean we can't biopsy it if it's sub-centimeter in size. Some of the things that will help when the imaging is done, the radiologist will report to you whether or not they think that the architecture of the lymph node looks perfectly normal or not. So sub-centimeter nodes, once they're suspicious by either length of time or radiological evaluation, can be biopsied as well, but generally speaking, a centimeter.
Would a lymph node with a fatty hilum on ultrasound still be considered suspicious?
Usually not, but we can't use that alone. We have to look at the other things. And some of the things that we need to look for is that the only area in the body that has an enlarged lymph node. Because if you're seeing other areas, then that is suspicious, irrespective of how it is described. Or other organ enlargement, liver, spleen, hypercalcemia, bone disease, anything else that is suspicious, even if the lymph node architecture seems innocuous or benign, it is worthwhile doing a biopsy. However, you're going to avoid the groin because, you know, the groin is a common place to have benign, non-specific enlargement of lymph nodes. So this is really referring to a lymph node that is persisting somewhere else or on the side of doing a biopsy or taking it out.
All All right. How long should a lymph node persist in a child before I consider it for biopsy to rule out NHL?
Well, that's a very difficult question and a very good one, in that it depends on what is happening in the child. Because if this is a cervical lymph node and the child has a lot of respiratory tract infections and so on, it might be very difficult to call. What might be worthwhile determining is how that lymph node is changing. Is that lymph node getting bigger, or it has remained relatively the same size, or has gone down smaller after the acute illnesses, but has enlarged again in association with some illness? So it's a clinical call. Very difficult to say a specific thing, to say, oh, wait 6 weeks, 6 months, or whatever. It's going to depend on the clinical situation in terms of if there's another explanation for that lymph node.
A question here from Dr. Ying. When you list bone scan as an investigation for multiple myeloma, do you mean skeletal bone survey via radiographs or nuclear medicine bone scan?
All right, the comment there, usually we don't do a bone scan to diagnose multiple myeloma, but that was included there because one of the studies I was looking at indicated that this is how they are picked up sometimes. So you're doing a bone scan for another reason. And I can give you an example of a patient who had breast cancer and was having a scan. And she had lytic lesions, and the logical thought would be that this is her breast cancer that has come back and has spread to the bones. But the radiologist, probably not knowing her entire history, suggested a workup for multiple myeloma, which was done. And her bone marrow, she had 85% plasma cells in the bone marrow. So, short answer, bone scan is not part of the normal evaluation, but the bone scan being positive in the absence of a solid tumor to explain it can be a clue to the presence of multiple myeloma, but it's not the usual test. So yes, what we would do normally is a skeletal survey, which is a plain X-ray from skull to legs, looking for lytic bone lesions, which would provide us with one of the criteria for the diagnosis.
All right, and the final question, at what point above the upper limit of normal is the serum globulin significant for MM?
There is no such value, as far as I know. And I'm saying that to say, as I indicated, some of the patients with multiple myeloma will have a low serum level, and I didn't get a chance to highlight it because I ran out of time. But the globulin level can be low, it can be normal, it can be high. So yes, the majority of patients will be high. What I tend to do is look for another reason why the globulins could be high. But it's easy to do a serum protein electrophoresis because in the majority of other cases, there is going to be a diffuse increase in the globulins. If it's a diffuse increase, then it makes multiple myeloma very low down on the list of possibilities. If you're finding an M band, it is significant because it means now that M band could be there because of multiple myeloma, it could be there because of non-Hodgkin's lymphoma, it could be there for macro globulinemia. All of these have significant implications in terms of the patient's survival. So once it is elevated and the person is not acutely having an infection, I would follow through with the serum protein electrophoresis and the urine protein electrophoresis.
Well, I want to thank you, Dr. Scott, for this bouquet of information to assist us with diagnosing of these hematological cancers when we see our patients. This has just added to the level of excellence that has been presented today, and we've seen today from all our presenters. Well, thank you again for this. And at this time, we are also moving on to another very, very interesting segment of our afternoon, where we are going to be dealing. This is the ethics section, and it's dealing with how COVID-19 has affected the quality, cost, access, and delivery of healthcare in the health sector. Hopefully, Jamaica, and perhaps some information on how it compares with what's happening overseas. I'm going to introduce to you our panelists shortly, very short introduction. And I will start with Dr. Andrew Manning, who is the president of the Medical Association of Jamaica, a consultant head and neck surgeon at the Mandeville Regional Hospital. He's a former president of the Junior Doctors Association, and we all know him very, very well, especially during these times when he has attempted to represent us with regards to issues pertaining to COVID-19. I'd also secondly like to bring on board Dr. Brian James, who is a consultant anesthetist and head of the Department of Anesthesia and Intensive Care at the Bustamante Hospital for Children. He was in 1998 awarded the fellowship for the Royal College of Anaesthetists in London. Dr. James is a former president of the Association of Anaesthetists in Jamaica, as well as the Junior Doctors Association, past president. He's a member of the Pediatric Association of Jamaica, British Medical Association of Anaesthetists in Great Britain and Ireland, and the Society for Pediatric Sedation. He's the president-elect for the Medical Association of Jamaica. Welcome, Dr. James. Then we have Dr. Lyndon Leish. Dr. Leish sits on the board of directors of Andrews Memorial Hospital. He is the president and chief executive officer of that hospital. Dr. Leish is a general practitioner who sees mainly children. He was trained in Mexico at the University of Montemorelos, which is a Seventh-day Adventist medical university. And I must tell you that he has been trained throughout over several parts of the world at Seventh-day medical schools. He came to Jamaica, worked with the government system for many years at Bustamante Children's Hospital and Victoria Jubilee, left Jamaica, attended Loma Linda University in California, another Seventh-day Adventist church, where he studied public health, and he had his master's and later in public health, and later did an MBA in healthcare administration. He has worked in the UK in pediatrics for several years before returning to Jamaica. I think he worked also in pediatrics at the Mandeville Hospital. Later traveled to Guyana as a medical missionary and became medical director to Davis Memorial Hospital, a Seventh-day Adventist hospital in Guyana. He returned to Jamaica 1.5 years ago as the CEO of Andrews Memorial Hospital. He's married with 3 children, and he is very, very interested in photography. And last but not least is our very, very dear family physician, Dr. Peter Swaby, who was trained at the University of the West Indies and is the managing director of Apex Healthcare Associates and is the CEO of Hope Worldwide Jamaica. Hope Worldwide Jamaica, which is a charitable organization involved in the HIV/AIDS prevention programs in Jamaica. It's a nonprofit organization, and this is a current ongoing organization. Dr. Swaby is a recipient of the Hbss Scholarship and completed his MBBS from the University West Indies in 1986. He then trained in full-time ministry for the International Churches of Christ, where he served as an evangelicalist for this church in Kingston. I must also state that this Hope Worldwide Jamaica targets underprivileged communities in Kingston, St. Catherine, and St. Thomas, providing mobile healthcare services. So Dr. Swaby is a past president of the Association of General Practitioners of Jamaica, and he currently serves as the treasurer of the association. He also continues to maintain a full-time GP practice at Apex Healthcare. And I must say Dr. Swaby is one of our model family physicians who we hope our young colleagues who may be listening in here today will seek to emulate. With this, I'm going to ask Dr. Swaby to take over as not only the participant, but the moderator of what will now be a panel discussion on these ethical issues about COVID-19 and its costs to the healthcare sector. Dr. Swaby, over to you.
Thank you very much, Arna. Really appreciate the introductions. And to all our panelists who are on with us right now, I'm going to ask, since I am one of the hosts of this conference, for Andrew Manning and Brian and Lyndon in that order to do their presentations. I'll present last and then moderate.
All right. Thanks very much, Dr. Swaby. Am I able to share my screen?
Yes, sir, you are.
Okay, give me a second to load up my... And while I'm doing that, I'd like to say thank you to the organizing committee, in particular, Dr. Donald Gordon, the president of the association, for inviting me to be a panelist. And I'm going to speak briefly on COVID-19, the impact on quality, cost, access, and healthcare delivery. I was given an option to look on this as it pertains to my particular specialty. And that's what I'm going to be doing now. Firstly, can everybody see what I'm sharing?
I can. Sure.
Okay,
yeah.
So firstly, let us look on a definition of quality healthcare delivery. So the National Committee for Quality Assurance has published a document in which they have two definitions. The first of which states that quality healthcare is defined as safe, effective, patient-centered, timely, efficient, and equitable delivery of healthcare. Another definition by the same agency speaks to healthcare being, or defines quality healthcare as doing the right thing for the right patient at the right time in the right way to achieve the best possible results. So whether you are talking about high-tech delivery of healthcare or low-tech delivery, you have to do the right thing for the right patient in a timely fashion. Now, a little bit about me. I am a consultant otolaryngologist. I practice mainly in central Jamaica, rural type of setting. And I have a public practice based at the Mandeville Regional Hospital, and I also operate a private practice. In terms of what I do as a ENT professional, I manage an ENT clinic. We see outpatients there. I do office consultations and follow-ups. I do various procedures, surgical procedures. I am a cancer surgeon, and of course, I provide some amount of emergency care. Now, let us look at what has been happening in the ENT outpatient department at Mandeville as a result of COVID. So prior to COVID, we would see in our department about 160 patients per week. We have 2 clinic days, a smaller clinic on a Monday and a larger clinic on a Wednesday. And prior to COVID, typically in that outpatient department waiting area, which we share with other specialties, you would have a packed waiting area with little or no social distancing. But we were seeing about 160 patients per week. Now, COVID has definitely impacted this. From early on, we decided after consultation with the Ministry of Health to scale back the clinic, not just the ENT clinic, but other services. And we did this really so that our clinic activities wouldn't amount to or wouldn't create a super spreading type of situation. And so we actually closed the clinics for a couple of weeks in a way for us to reorganize the service so that we could be seeing lesser patients with a view to having less patients waiting in the waiting area. We would then be able to allow for social distancing within the waiting areas. And it also allowed us to roster the staff in a way that minimized the risk of the entire team contracting COVID-19 at the same time. Now, as a consequence of this, we have definitely seen longer waiting times, both in terms of persons coming with referrals to get first appointments. We have had to implement longer times between appointments. And obviously, just based on the definition of quality of care, this has had a significant negative impact. So with respect to our outpatient activities, we've seen significant delays. The patients have had decreased access to care. And with respect to that, we also found, certainly in ENT, that many patients themselves decided not to come out and seek care due to fear of COVID-19. And this is something I've heard from other specialties, and I've heard this from other GPs. Now, let me move on to the impact on my surgical practice. Now, COVID-19 has been shown by numerous studies to have potentially adverse effects on both patients and caregivers, including surgeons, anesthetists, and other support staff in theater. In fact, otolaryngologists, because we commonly operate in the airway, and anesthetists who peek down the airways every day, are at particularly high risk because of the risk of being exposed to a blast of virus or a high viral load. So with respect to surgery in COVID-19, serious questions have arisen worldwide, and these have been questions with respect to pre-op COVID-19 testing, the availability and use of appropriate PPEs, diathermy use, appropriateness of continuing elective surgeries. And as I alluded to, some surgical procedures, especially for ENT, carry an increased risk of aerosolization of viral particles. Now, the Association of Surgeons in Jamaica produced a statement, and I am a member of the Association of Surgeons in Jamaica, and produced a statement on surgery during COVID-19. It was recognized that many international bodies consider it best practice during COVID to suspend elective surgical procedures, and we concurred with that. Certainly, we hoped that we would reach to a point where we would have easy access and consistent access to availability of appropriate preoperative testing of patients and also a ready supply of PPEs. We did recognize, however, that you still had to deal with the surgical emergencies. So the position of the ASJ is that you should not have any delay in the offering of emergency surgical care because you couldn't get back a COVID test. And we placed cancer patients who needed urgent surgery in that kind of category. We recognize that you still have to go ahead with your cancer cases, even if you don't have a preoperative COVID test. We also recognize, though, that especially with the onset of community spread, you have to regard all patients as potentially having COVID-19, whether they're symptomatic or not. And so the need to have the test, although we still have the need, it's not as pressing, but what is pressing is a need to have full personal protective equipment appropriate to the particular type of surgical procedure. It was recognized and we advised that wherever possible, alternatives to surgical interventions were shown to be non-inferior and cost-effective be considered for the patients. The problem is for surgical patients, if you need surgery, most times that's what you need, certainly for most of the conditions that we treat with. So during the pandemic, certainly in the ENT service at Mandeville, there was a drastic decrease in elective surgeries. This really didn't apply to the obstetric and orthopedic departments. And even though we recognized that, well, we recognized that cancers were emergencies and we did the best that we could to continue dealing with our cancer patients, and emergency cases were carried out. There were some challenges though. Getting pre-op COVID tests has been a real challenge. It's not easy to get a test, and I don't think there has been any time during the COVID-19 pandemic that I could say that getting a test has been easy. So you say, okay, you can't get the test, but go ahead as long as you have appropriate supplies and types of personal protective equipment. Well, that has been a big challenge. And in fact, there have been times during the crisis where, certainly in Mandeville, we have had to hold back PPEs due to low levels in order to facilitate emergency surgeries. And what that means is that you have a further delay of your elective surgeries, therefore significant delays in delivery of care. With surgery, remember that when you delay your elective surgeries, that same patient would probably need an emergency surgery down the line. So an ethical question that we can discuss: are these delays justified in the context of COVID-19? Well, I think they were, because if these were not taken, the impact of COVID-19 would have been catastrophic. I was asked to look at a bit on the impact of cost. Now, recognize that, you know, we could have spoken about cost to the system, cost to the patient, cost to the practitioner. Because of the limited time that we have, I've chosen to just zone in a bit on the cost in my practice. I'm sure other doctors would have similar stories. In addition to your universal infection prevention and control procedures that all of us would have been carrying out, as a result of COVID, I've had to buy more masks. My receptionist never used to have a mask. She has to have one now, fresh mask. And we have masks there in case a patient arrives and needs a mask. We have had to invest in more PPEs, increased use of hand sanitizer, increased level of environmental cleaning and disinfection. With respect to my endoscopies, it has had a significant impact. This is a picture from perhaps the leading text of otolaryngology for residents in training. And this is how we do a flexible endoscopy. As you look on the picture, you would recognize that this is a pre-COVID era. When you do an endoscopy, you're in front of the patient for anywhere from 5 to maybe 10 minutes, or maybe not as long as 10 minutes, but you're within 2 feet of the patient. So this is actually a very high risk procedure. You don't generally get a lot of aerosolization due to the procedure itself. But whenever you're working in the nose, you do have an increased risk of the patient sneezing or coughing. Prior to COVID, this is the kind of setup that I would have had to have invested in. Now, you have to buy your impervious gowns, your face shields, your towel, because really the move now is to use a video camera so that you don't have to have your face up close in front of the patient. And of course, the much talked about N95 mask. This is a popper device, maybe not used for endoscopy, but this is something that we should be using when we're doing tonsillectomies and so on. In terms of dollar figures, just on the screen there, you're easily looking at about $60,000 US, easily. So we have had increased costs. Ultimately, these costs clearly would have to be passed on to the patient, certainly in respect to the private practice. It's a challenge now to pass on those costs because the patients themselves are feeling it. So in conclusion, there's no doubt that COVID-19 has impacted healthcare delivery, certainly in my practice. But let us look on the flip side. And in this part now, I'll briefly put on my MAJ president hat, because changes are now being implemented, which may actually positively impact the care of the patients in years to come. In my 23 plus years as a doctor with government, I've never seen such investment, such improvements in physical infrastructure, such an increase in the number of ventilators than we've seen in the last few months due to COVID. We've now doubled our ventilator capacity potentially. Some of the changes that we're making now, bear in mind that COVID-19 is going to be with us for at least a few years, and we may have other viruses to face. We all have to deal with a new normal post-COVID-19. There are going to be questions with respect to the impact of the vaccination program, certainly in terms of how we deliver surgery. I suspect that it's going to change the guidelines as to the requirements for pre-op testing and so on. And in closing, one of the potentially positive effects of COVID-19 on healthcare is that it has brought healthcare delivery in Jamaica and worldwide into a sharp focus, a focus that it hasn't been in for centuries. Everybody now is concerned about healthcare, and this is a time for us to have a frank discussion on a need to revisit the healthcare budget in Jamaica. I suspect I've gone over my time, Peter, so I'll conclude here. I say thanks again, and I'll be available to answer any questions.
Thank you so much, Andrew. Excellent summary. At this time, I'm going to ask Brian, if you would, to go ahead and share his screen and present. And you have 15 minutes, and we'll look forward to your presentation.
Thank you very much, Peter. I need to just go directly into what I have to say. I don't want to go over time. So I'm Brian James, anesthetist. I was generously introduced earlier. What I'm going to speak about is the effects of COVID, public sector costs, healthcare costs. All right, so what I'm going to try to do, I'm going to try to keep it relatively practical. So I'm going to look, what is the current situation, how many cases we have, etc. What is the healthcare budget, including the supplementary estimates. Second supplementary estimate that came out in October. I'm going to zone in on the N95 math, the usage pattern and the cost and so on. And I'm going to look at ICU. UA is the main ICU for COVID-19 in Jamaica. So, and there is some data that I have from UA, so I'll go through that. Then I look at a study which projects costs in the US, and try to see what it can do to extrapolate to Jamaican reality. All right, so what's the global reality right now? Well, as of Friday, 87.586 million people have been confirmed, and 1.9 million people have died. So this is real. This is something that is affecting the entire world. How about Jamaica? Again, as of Friday, they've added a few since that. We're probably nearer to 13,500 now. 13,411 confirmed cases, 307 deaths, and we are well and truly in community transmission. What of the budget? The budget, of course, was crafted starting from last year, August. Not last year, 2019, August. So when it was being crafted, it clearly didn't have anything to do with it. It was envisaged that COVID was going to be an issue for us. Ministry of Health was allocated 77.9 billion Jamaican dollars overall. There was a bit of an adjustment in the first supplementary estimate. They added 1.5 billion to it. I'm not sure how visible this slide is, but I want us to look at the bottom right-hand corner. And it is telling us that when they revised the budget in October, they decided that on the recurrent side, they're going to add $1.1 billion. That is going to be made up of 550 million for compensation of employees. Remember that you have primary care people. There was an offer of some amount of money for people who are actually dealing with COVID positive. So travel expenses and subsistence, 84.3 million. Rental of property and machinery, 177 million. Use of goods and services, 250. I'm not sure exactly what that represents. Overall, $1.1 billion on the recurrent side. Remember that. There was in May an additional amount of $2.5 billion. I'm not sure exactly where it came from, but I mean, I didn't see it in the budget at all. It may have come maybe from some catastrophic fund that is available or something, but 2.5 billion was allocated to contain the spread of COVID-19 and ensure the best possible health outcome. Of that, 750 million to the regional health authorities for capacity building, 200 million to University Hospital of the West Indies, because the idea was that they were going to be sort of central to the COVID response. 500 million for prescription drugs, that I'm not sure exactly what drugs they were. 304 million to procure PPE. I'm going to come back to that to some extent, because by the time our first little blip on the screen came, that money evaporated. 195 million to procure 32 ventilators. From what I can see, that has already been done. And 2 million for initial procurement of test kits. That is a little bit murky for me. I'm not exactly sure how much a test kit costs, not just a test kit, to do the test. And as I go along, I'm going to tell you what my estimate is or my assumptions are. Okay, so let's do a comparison between ourselves and the United States and Trinidad. Trinidad is close to us. They have similar sociological experiences as well as geographic proximity. The United States is kind of the benchmark for everything, although now a lot of people might want to argue with me of late. So in the year 2000, the US spent $4,562 per capita on healthcare. In that same, all of this is US dollars. In that same year, we in Jamaica spent $196. In Trinidad, they spent $259. And they went up, all the countries went up. Jamaica went down between 2000 and 2005. May very well have been because of exchange rate changes. Up to 2015, the US, they're up to $9,536 per capita. We are up to $294 per capita. Our dollar is nearly 150 to 1. And Trinidad, they're up to $1,146 per capita. I think maybe it's about 7 to 1 in Trinidad. Somebody can correct me if I'm wrong. So what I did was to take an average of US numbers and an average of the Jamaican numbers and divide them into each other. And there's a factor of 32. The United States, typically over this period, and I didn't include the 2020 figure. Over this period, they spent 32 times the amount of money on health as we do. So remember, in May, there was allocation, because by that time now, things had started to get a little dicey for us. And so there was some allocation of 2.5 billion. And then, there was negotiation to see how this was going to be increased. So the Ministry of Health and Wellness, according to Mr. Duncan Bryan, was at the time currently in negotiations with the Ministry of Finance and Public Service for additional funds. And he continued to say the needs across the whole of government is significant, given the scale of COVID-19. And so these negotiations will take a little time, right? And they will advise us of the results. Some of us might have seen it. All right, so what they did during that period of time was to engage the National Health Fund to do all of the procurements related to COVID-19. And when they were given this challenge, they embarked on an impact assessment. And this is the result of the impact assessment. And they've sort of revised it as they've gone along. Clearly, there's increased demand for PPE, for ventilators, and for other medical equipment and supplies. What they realized was that traditional sourcing methods were inefficient. So they had to take action where that is concerned. Of course, what we are trying here to talk about, money. The prices for some PPEs rapidly increased due to demand. I mean, in Jamaica, we call that teeth, but in economics, that's just supply and demand. Masks went up over 100% from the time they first got quotes from people to the time they were writing this. The masks had gone up 100%, gloves 500%, gowns over 700%, and syringes over 60%. Okay, as I was saying, these kinds of activities were not included in the budget. They had to find sort of extra budgetary means of getting it. I wanted to touch a couple other things in their assessment, although they weren't priced. They were having problems with manufacturing capacity across the globe. Because of the increased demand, supply was reduced. Of course, you can get therefore more money for it, and you're going to add to it. They were having difficulty with the fact that there were new suppliers in the market. They found that the new suppliers did not necessarily always provide authentic and high quality products. They were having a lot of difficulty with that, and they had to do a lot of testing and verification and so on. Right. So another thing that they did at NHF, and this now came in December, they asked all the regions to provide them with an
All right, that looks like an internet problem. Dr. Swaby, you may want to ask Dr. Leach to do his presentation until Doc comes back.
Sure. Are you prepared, Lyndon, to go ahead right now?
Yes, I am.
Yeah.
All right. Good afternoon, everyone. What I would do is I will get off of the camera to help with the bandwidth, because I think that was the problem you're having, and just use it without the camera so you can all hear.
We're good with bandwidth over here, but if on your side it's glitchy, sure, you can do that.
Fair enough.
Mm-hmm.
Let me just connect.
While you're connecting, Lynn, I'm going to ask if you can get Doc back on. Maybe I don't have a number for him, so if you could just get him on the phone and check if maybe he had JPS issues or flow digital issues.
I'll WhatsApp him, Sam.
Sure. Thank you. And Dr. Leach, we're seeing your presentation on screen now. So
It's up there?
Yeah, we just needed to go full screen and we're good to go.
Okay. No, a second.
Yep,
Okay.
That's the first page. We're seeing everything clearly.
Wonderful.
Thank you.
Okay, good afternoon again, everyone. And thanks for the opportunity to present to you this very important topic of COVID-19 effects on healthcare quality, cost, access, and delivery. As you know, I represent Andrews Memorial Hospital. And unlike what Dr. James was doing a while ago, I will not put some numbers for proprietary reasons and for competitive reasons because we share a competitive environment in the private sector, but you'll get a bigger picture. So the pandemic has highlighted what is possible in healthcare from our perspective when roadblocks to innovation are reduced and cooperation becomes a norm. And I stress cooperation becoming a norm. As we face this, from Andrew's perspective, face an unprecedented financial and operational pressure, hospitals and healthcare systems, including other private healthcare systems, from our perspective, we've had to change our model of care. We have had to alter our revenue cycle in terms of what we do and expand the use of digital technology to deliver care. And I'm going to stress two things: prioritizing patient safety and staff safety. And just remember those two words. Prioritizing patient safety, prioritizing staff safety. And it's important to remember them because they have some negative effects from our perspective, how it affected us in the long run. So we have had to act. Hold a second, I'm not sure which slide I'm on here. Let me go right back to, okay. Right, so I guess I'm on the right slide here. So we've had to act pretty fast from Andrew's perspective, where we have to put in plans to expand the surge capacity. And indeed, there was a surge because when we looked in February, COVID hit the US late January, early February. And we were thinking, it probably would get to us. And in March, it came. And as we started to plan, so we've had to expand our surge capacity and put things in place to expand the surge capacity. We've had to come up with ways to secure proper supplies. We've had to establish new pathways for screening. And those new pathways for screening and new clinical protocols for the safety of our patients and staff to deal with this new norm within the healthcare environment. We've implemented a screening station for all persons entering the facility. And Andrews Memorial Hospital had identified, and we have designated that isolation area, established an alternative flow for patients presenting and with probable symptoms. And that's important because as we did that, it became, for some persons, took a negative effect to that because they wonder why we were doing that. An isolation holding room was established within the OPD for administrative purposes, administrative care and treatment. We communicated that with the Ministry of Health. They came and they looked at it and approved it. And to arrange, also we have to arrange for transfer arrangements with other facilities, those who have active ICU, i.e. KPH, University of the West Indies, in case we need to transfer such patients. Going back to the screening bay, we implemented an introduction to screening bay or a hand washing station before you enter the hospital. And of course, you had to go through answer a series of questions where you had your temperature checked, you were given a mask. At that time, you were given masks because it does not, well, not everybody was using a mask, and had the ticks of the questions from the CDC and Ministry of Health before you can enter the facility. To the chagrin, some of our fellow physicians were not welcoming in that process because it was relatively new. However, those are the things we had to adopt to move pretty quickly. But what we realized early in the game is the adoption of technology was important for us. And during that time, we proceeded to develop telemedicine. We developed a platform for telemedicine. And the idea was to rush the telemedicine onto the market. However, like everything else, as you try to rush it onto the market, you realize there were some issues in terms of compatibility, payment, etc., which we had to step back to be able to resolve those issues. Suffice to say, we have completed that process and we'll be offering telemedicine. So for me, that was the most obvious healthcare transformation that took place from our perspective. And if you look overseas, it will be the same thing with the use of telemedicine. Hospitals and healthcare systems across the board, and for Andrews also, we focus on optimizing the patient experience. As a private institution, that's also one of our primary objectives, is for the patient experience as a way that people can seek and receive care. And considering COVID-19, the bigger issue here from a financial perspective, the financial component of the patient experience became a key factor in this pandemic. Because as you started in March, and when we looked across the US, when businesses were closing, people were laying off, it became a challenge to what would happen in Jamaica as a private institution, how we will manage that fallout. We sought to, and I'll explain a little more about that in a minute. We sought a private-public partnership for the delivery of healthcare through the Ministry of Health, so we can work together so we can help resolve the issue. Now, Andrews, we willingly offered to partner with Cape Kingston Public Hospital, which some of you would remember, to accept the non-COVID patients in our facility. But the financial cost was important to us because at that time, and as you go from March, April into May, when people were beginning to understand what COVID was and they were afraid in one way to come to the hospital, other facilities, not only hospitals, but entities within Jamaica were cutting their staff. It became evident that this had a significant financial layout for which we never budgeted for. That created a problem. So we had to think of a new approach to finance this entire aspect of healthcare. In that, prior to COVID, there were long waiting times in the waiting room, or just to see the patient, for the patients to see the doctors. So patients were concerned about the waiting times. People stopped coming. We had to figure out a way. But in terms of the waiting time and looking at social distances within the emergency room or the OPD, the fact is that, I'll give you an example. At that time, we were seeing about, let's say, 60 patients in our OPD per day, roughly 60 to 70 patients per day. And suddenly those numbers were cut, not in half, but we went down to about seeing 7 to 10 patients a day in the OPD. Now, to add insult to injury, again, from a financial perspective, when I spoke to you about, and I said earlier, look at in terms of safety for patients and staff, we had a significant financial outlay for PPEs. And I know Dr. James mentioned that, and Dr. Madden mentioned that earlier. But we never really are part of a system where we stock all of these. So we had a situation where we never had sufficient PPEs to offer. So we had to look overseas to our sister hospital, Florida Hospital, to get some, and they had to then finally ship them in. So we had a waiting time. And what happened is when we assess as we move forward, there was a significant exposure risk to our staff, where six of our doctors, nurses and doctors became exposed, and one I think most likely contracted, but it was a negative test, but the way she felt it looked like COVID. So we had to make a decision in the light of when you don't have enough PPEs, what would you do if you continue down the same road, seeing patients without enough PPEs, and in 1 or 2 weeks of the COVID, 6 persons were exposed and had to be isolated for 14 days, then that risk increases for your staff. Sooner or later, the entire staff will have a problem and the hospital will run to a halt. We made a decision which we put out there saying because of the risk, we will not be able to do that in terms of seeing so many patients and then stick to the protocol, which became a negative for Andrews, and that added insult to injury to our numbers. So right away, we had a problem. We had a major problem in terms of how we proceed, where the numbers reduced from over 70 per day to about 7 to 10, then it finally went to about 4 to 5. The issues of elective surgeries, again, as Dr. Madden had mentioned, we had to adhere to that protocol and reduce elective surgeries, and only allowing for emergency surgeries. And then there was a protocol for emergency surgeries to have testing done, and we were not able to access testing at our institution. So all of that created a problem financially. Now we had a staff, a large staff to keep up with, and other places were cutting staff. And we made a decision at that time, should we really lay off half of the staff? Obviously, looking at what we were doing, could we lay off half of the staff, which will help us moving forward? Let's see the slide I'm up. So that decision was a difficult decision to make in terms of laying off the staff. And we decided, I'm gonna see if I'm going back. Let me just go back to this slide, right? Slide number 4. So the decision was to keep our staff, one, to add value to the staff, because of the years they've worked at Andrews, considering the financial problems we were in. We lost over 80% of our income or revenue as a result of this, but yet we had to keep the staff. And we decided the best way to do in a stepwise fashion was first, yes, we keep the staff. We will implement a system where we ask for a pay cut, a 50% reduction in their salary over a 3-month period, and reassess every month to decide if we need to go to 20% or 25, 30, 35%. Once we got to 50%, then we make a decision to lay off half of the staff. So far, we haven't gotten there yet. But that financial implication was significant because Andrews, until this day, has not recovered the significant revenue from that period of time. So the cost of COVID to a private institution in this environment has really created significant hurt to us as how we do our operations. But suffice to say, the pandemic has helped us as an institution and the providers to integrate technology. Hence came the technology looking at telemedicine as an adjunct to work and getting around. And so we have created a platform. So patients don't necessarily have to come in per se at this point in time, where they can register on the platform and then they can be seen. The platform allows for payment. So it pushed us into a position to be innovative. This process related to the direct payment system, as I mentioned, made up another component of the care experience we have for patients. However, as the patients are becoming more comfortable with varying aspects of the technology interface, as we go along, a more convenient digital payment system will ultimately come into place. This highlighted the fact that we need to, as a private institution, again, also with government, we need to invest in a system that allows us for pre-registration and for the older generation, for patients who have to be a part of it, to look at how we can help them be part of that system, because more than likely this technology era only fits into a certain age group of patients. Not gonna be long. The sustained collaboration and trust. What this has done is push Andrews, and I would suppose other healthcare providers, into working for the better tomorrow in sustaining collaboration and trust. We've had to work closely with the Ministry of Health in developing a partnership, a private partnership, where we can work together to address these issues. And the truth is, this has been difficult, but we have realized that there's only one way we can survive in this market, not only as a private entity, but in order to make a difference for Jamaica, is to force those boundaries to be able to do it together. So while the digital technology can help streamline patients' financial experience, well, we still see this familiarity in Jamaica with experience with the deep financial difficulties. The question we have here is, as COVID continues to progress and patients continue to have significant financial fallout in their revenue in terms of jobs, the difficulty comes in as a private institution when we have such a large layout in cost for PPEs, for diagnostic criteria in terms of testing, and to outlay a system to support social distancing. That cost has to be transferred to that to be able to offset it. At the same time, in a private setting, one has to keep a cost down to be attractive and competitive. And how do you work those two? We have looked at areas where the patients who come in who may have financial challenges to work a payment plan structure. But even in working out a payment plan structure, there's always the possibility as when you cut a deal in terms of paying, the patients will disappear, and of course you'll lose the income. So it is difficult financially, the difficulty in trying to do this. But however, the public-private communication gap continues to be narrowed. And we continue to work with the Ministry of Health, as I said. Lack of resources is an issue which we still have a challenge with, because earlier in the game of COVID, resources became an issue. And I remember, so Dr. James mentioned that too, and Dr. Madden, finding PPEs was a problem. And even now, since there's much more in production, it still comes at a high cost because the price of PPEs went up significantly. But we have to look at that and see how we can share costs. The issues we have had with delayed dissemination of patients, in sending patients to private hospitals was a problem working with the government. But again, it will help us to narrow that and work together as we try to move forward. I believe from a private hospital, as a private hospital, the discussion needs to be around how does government assist the private sector, i.e. in private hospitals, in bridging that gap. If you look at other countries, even though there are private hospitals in the US and in Canada, there was significant government funding to assist these hospitals to survive. In our situation, there was no such funding. We are basically left on our own to figure out a pathway while still being competitive and at the same time to offer care at the standard guidelines listed by the government, which makes it very difficult. So ultimately, and I come to the end here, as we continue to collaborate for the future, we need to develop infrastructures, services, and policies that will help us move forward with this. Enhance the cooperation with individuals within the healthcare industry, integrate technology in healthcare, reduce overall waiting times as we look at a new norm of social distances within the hospital, which will reduce your income. However, on the other hand, with an online platform, help persons to get onto that platform. And last but not least, I think not only Andrews, but every private institution, we need to figure out a way that we can all be involved as a group in the national emergency response. What happened in this response that private sectors were left out of the response? So when the money poured in from the government, it was only for the government institutions. Yet at the same time, the private institutions played a role, but suffered significantly because of the financial fallout. I think that's my last slide, and I'll be happy to, when the time comes, to take questions as to some details as to what we've had to do to still stay alive in these difficult times.
Thank you so much, Lyndon. Appreciate that. I'm going to have Brian James share his final slides with us since he got cut off. And I'll make my presentation 5 minutes, and then we'll have time for question and answer.
All right, thank you so much, Peter. I don't know what happened. I think it may be a cost issue or a virus of some sort, hopefully not COVID. Did you see this slide?
Yeah, I think we were at this slide. Let's see the next one. Let me see if we were there, Dr. James.
don't know if you take off the video might help you with the web with the bandwidth. I think some people complain about they couldn't hear properly, and that's the problem. It was going in and out for me too. I don't know if that
Right, but that's a bandwidth issue on their side that you turning off your video won't help them in any way with that. They need to actually just try and connect to Wi-Fi or use some other source of internet. So
No
that's totally fine.
Right,
So yeah, I
let's
think I
start
remember
here.
this slide. Yeah, go ahead, Dr. James.
Right, so basically the essence of this slide, I'm really sorry for this. Essence of this slide is that overall cost between the estimated or projected cost between January and June 2021 for all the regions is going to be about $4 million US just for N95 masks, which is not a good thing. The next thing I wanted to talk about was testing. We have done 144,288 tests so far in the pandemic. And my estimate, I haven't been able to actually get a cost. I estimate that each test will cost about $100 US after I check around. And therefore, you're talking about $14.4 million. You see the costs are adding up. And what I wanted to do was to point out that we are spending $13 million on testing people who are negative. So don't be too hard on the Ministry of the NPHL when they want to focus their testing, because it's very costly. All right, so the last thing second to last thing I want to do is go through a couple things about UE. They've admitted 179 patients up to recent, about 3 weeks ago, and 45 of them were admitted to ICU. I spoke to them and they've informed me that ICU cost is about $3,000 US per patient per day. The median stay on ICU per patient is 21 days. Do you know that means that each patient will spend about $63,000 US if they're lucky enough to survive this ICU stay? The mortality rate is about 60%. The grand total so far spent on ICU is about $2.835 million US. And when I was told about it, I thought to myself, why are we thinking about the mortality rate from COVID? I think I would have a very high mortality rate from the bill. And finally, I'm going to go through a little estimate, a little model that was developed in the United States in New York by some people from City University. It's a completely university-based model. And they estimated the resources used per patient for symptomatic infection, and then extrapolated it nationally. And then they applied 2 different attack rates, 20% attack rate and 80% attack rate. The 80% is what some experts, quote unquote, want actually to expose people to, so that they can have herd immunity without needing a vaccine. And what they came up with is that each person with symptomatic infection who didn't need to be in hospital, they would cost the system or themselves, depending on where they are, $3,045. When I was saying that we spend 32 times less, so I've calculated that at $95 US. Each person with symptomatic infection needing hospitalization, they would spend $14,366. And from my little Jamaican sort of extrapolation, that would be $449. If you add to that follow-up, right, which is something that not a lot of people know about as yet, it goes up to $18,500. So effectively, if they apply a 20% attack rate, in Jamaica, we'll be looking at spending $5.1 billion US. But remember, the overall Jamaican budget is $5.8 billion US dollars. So can you imagine if we did the herd immunity naturally, we would be talking about, it's quite a number of people dead, a couple thousand well, and we would have to find 20.4 billion US dollars. So in conclusion, there is a significant direct cost associated with the pandemic, more than 5% of the total health budget so far. There are other indirect costs like neglected and non-communicable diseases, capacity issues in the hospital, and therefore expansion of capacity, etc. The imminent vaccination program is going to be a new and fairly big cost. It is important for us, including the government of Jamaica, but the people I'm speaking to be very cognizant of these realities. Preventative measures are very important in reducing costs. Thank you so much. I too am willing to answer questions. I've told you pretty much all that I know, so I won't have much to add.
Thank you so much, Brian.
Over to you.
Thank you very much. I will just, quickly share my screen and
let me unshare mine. You stop me sharing?
Yeah, man, it's fine. Dr. Swaby can share now.
Okay, great. All right. So my presentation will be in the form of a case presentation. Quickly, you know how COVID-19 has affected our clinical care and the rapidity with which we can make diagnosis. And there are various things that impact on that. We have to manage our risk as healthcare professionals while still trying to practice good medicine and saving lives. So I have a patient, KW, is a 44-year-old male with hypertension, and he was exposed to a COVID-19 household contact. He was in the house. It was suspected that their 6-year-old, who had been going back out to school, brought it into the house. And the household member tested positive on the 13th of November, and he tested negative. They were in the same house. The following day, however, he became symptomatic for some kind of illness with night fever, malaise, and he was still on quarantine at the time, so he really by right should not have broken his quarantine to come out and see a medical doctor. But I was going on vacation on the 24th of November, and I said, listen, I'd like to see you before I leave so I can assess if you need any emergency treatment. When he came in, he was afebrile, his PaO2 was 98, and he had normal vitals. But the ethical issues were that, should he have come out of quarantine to come and see me? Should he have done a retest to see if he was positive for COVID? Was it an issue that he had tested too early for COVID and so had a negative PCR test? Well, he continued to have fever, documented fever, and on return from vacation, he visited me again. The first time that he came, he was seen outside because of his possible COVID positive status, despite having a negative test. But he came to visit me on the 3rd of December. And at that time, I noted harsh breath sounds, posterior mid and lower zones, did a chest x-ray on him, which revealed a left bronchopneumonia, left elevated right hemidiaphragm, and I started him on levofloxacin for 7 days. These were also his blood tests. He had a hemoglobin of 11.3, white blood cell count of 25.7, elevated platelets as well, and he had toxic granulation and an ESR of greater than 130 and rouleau formation seen on the film. Because of his elevated right hemidiaphragm, we decided that we were going to do an ultrasound just to make sure he didn't have any subphrenic abscess or any other pathology going on. And it showed an inhomogeneous enlarged liver with features of fatty infiltration, non-specific splenomegaly, and a contracted gallbladder with intraluminal sludge. He had a solitary enlarged retroperitoneal lymph node with minimal peritoneal fluid, and correlation with liver function was advised. He returned on the 10th of December, and he had been afebrile for 3 days on the levofloxacin, but he was still experiencing malaise. His lung symptoms were not as pronounced, but I continued the levofloxacin for another 7 days and repeated his blood tests. His repeat blood test showed a lower hemoglobin of 10.4. The white blood cell count had come down, as did the platelets. However, as we went on with the ESR was still elevated, I had added the liver function tests and blood proteins, and he had an elevated globulin. He also did ferritin, ANA, calcium amylase to see if there were other contributing causes. Ferritin was significantly elevated. And I also did electrophoresis, which showed a monoclonal gammopathy. And he was subsequently referred to hematology. But in the midst of COVID, it was a very confusing picture. Does this man have COVID, or is this something else going on? And finally, something that we can all relate to, a 58-year-old male with hypertension, whose last visit was in March, requested a refill prescription on the 18th of November. He was concerned about visiting due to COVID-19 and told to stay in his vehicle until he was called. But I told him, you need to come in, I can't just refill the prescription. He came in, his blood pressure was on the 23rd of November. Blood pressure was 150/90, pulse was 74. With some irregularity, I did an ECG, which showed AFib with controlled ventricular response, referred to cardiology, confirmed that he had AFib. But you know, these are some of the dilemmas that we face daily as general practitioners. Is this, do we extend people's prescriptions? Do we bring them in and see them, and we still have the onus on us to practice good medicine? That's my presentation. Now time for question and answer. I will stop sharing my screen. So at this time, do we have any questions from our panelists? And I'm going to ask Sam if he would to field those questions for us and give them to our different panelists.
All right, thank you so much. Wonderful presentations. The first question I'm seeing in the Q&A is from Dr. Suri Komradi. Is it ethical to ask only the patient for pre-surgical COVID test without asking surgical and healthcare team for the same test? I'm thinking anyone could answer that, or all persons give their own feedback and feel on it.
Andrew, would you like to answer that?
All right, excellent question. Fair question. I'm not sure how practical it would be, given the limited availability to actually get the COVID test. All of us as healthcare practitioners and surgeons actually have been asked to do some amount of screening on a daily basis. If you look on the guidelines, you know, we're supposed to be checking our temperatures, and if you have any symptoms that suggest that you could have, you know, COVID, even if you suspect it, you really should have a low threshold to stay at home, so to speak. But the fact is, I don't think it would be practical in terms of having surgeons having to do COVID tests. I think the solution has to lie with availability of appropriate PPEs. And most of the PPEs that you wear as a surgeon really are designed to protect the patient, Because, you know, when you wear a proper surgical mask, it's really designed to stop spread of aerosols from you to the patient and to the wound. So I don't think that it would be an ethical requirement to, in the current context globally, to have surgeons doing a pre-op COVID test. That would actually mean that you have to do it every time you're going to operate. So I don't know how feasible that's going to be.
If I may jump in here,
Sure.
if you don't mind. I think what COVID has done is change the norms of practice. I think it's going to come a time, especially in this 2021 year, we as an institution will have to put in certain policies by stating that, let's say, Andrews Hospital, where the staff should be tested, doing at least a rapid test every 2 weeks or every month, so that you can monitor the staff to see who those persons who have COVID, even though they might be asymptomatic. I know in other institutions, they are actually monitoring the staff every 2 weeks by doing simple rapid tests. But it may come a time that we may have to do that just to answer that question, not to say that you have to test them every day. But if you have a group of surgeons coming through, if every 2 weeks you test them with a rapid test, then you can clear them for the next 2 weeks, so to speak.
Well, Lyndon, I see your point. The problem though, the rapid test, in particular well, I presume you're talking about the rapid antigen test. So the rapid antigen tests, certainly the ones that we use here, are really not sensitive enough for asymptomatic persons. All right, the ones that we're going to use here have been touted for persons who are symptomatic. If you don't have symptoms, it really the sensitivity really decreases. Sometimes it's less than 50%. But what I think is going to be a game changer going forward is a vaccination program, right? And I think healthcare workers in general should be among the first cohorts of persons who get vaccinated. And I can see a time where you may have some requirements, even though you probably won't have mandatory vaccinations for everybody. But I can see a time where for you to do certain procedures like operating and so on, you might have a recommendation that you have to be fully vaccinated. I think that would help to decrease the risk of transmission from the surgeon to the patient. The challenge with the testing, as I said, is that the rapid test may not be sensitive enough. And remember, you can do a test today, go outside and pick up the virus. So that's where I think the vaccination thing is going to play a big role. Brian, as a senior man in the thing, what do you think?
Yeah, well, I'm looking at it from a slightly different perspective. The probability of transmission from the patient to the doctor, the surgeon, or the anesthetist is significantly higher than the reverse, particularly those people who are working in the airway and so on. And because of the number of people who the patient would be likely to come in contact with and likely to expose, it seems to me that there is no ethical dilemma in asking the patient to be tested as opposed to the healthcare worker. Yeah,
I think that and you know, I'm a cancer surgeon, and there are some patients you can't hold on, you can't wait until things are ideal, but it really has to be a case where they kind of produce a type of bubble. Certainly the private patients, most of them have been able to get the test. Then you try and create some kind of bubble, bearing in mind that you can't control everybody's COVID status who comes into interaction with them. You're talking about surgeon, theater staff, nurses, and so on. But, you know, when they go home now, that's probably the riskiest time, especially if there are people visiting them and people have to take public transportation and so on. So I think you have to educate the patients about the need for this kind of bubble. You have to explain the risks incidentally, because after certain procedures, COVID definitely has been associated with increased adverse outcomes. You know, it can cause a myocarditis, chest issues, problems with blood clotting, and so on. But it's not an easy solution, but I don't think having mandatory rapid testing is going to be the way to go. I think vaccinations are going to be the next game changer.
And as you say, the post-op issues, Peter spoke about his patient. I'm not sure, I don't remember if he said actually tested positive, but the atrial fibrillation after this period of illness, the times are a little bit off, but atrial fibrillation may actually be a result of some of the things that Andrew just spoke about.
Great conversation, wonderful answers. Really wonderful question and topic, because you do have these questions that will come up, especially with social media now, and you do know where some doctors maybe are on social media announcing that they became COVID positive, etc. So you can see how patients would want to know what their rights are there. From Dr. Andrew Gale, question for Dr. Brian James. Has the increased approach to regional anesthesia assisted in the cost effectiveness of surgical cases amid COVID pandemic as opposed to the general anesthesia?
Oh, most definitely. Of course, regional anesthesia is less costly in all kinds of ways than general anesthesia. But there are some cases, for example, the ones that Andrew would be interested in doing, that are just not amenable to regional anesthesia, right? But yes, the short answer is yes.
Okay, wonderful. Next question from Dr. Rattray. Wider testing is expensive, but wouldn't it cost Jamaica less in the long run, given the high cost of carrying COVID patients, or I think this is caring for COVID patients, if we chase the virus instead of the disease? Countries that do much better. So again, wider testing is expensive, but wouldn't it cost Jamaica less in the long run if we chase the virus instead of the disease? Anyone wants to tackle that one?
Well, I'll speak to a particular aspect.
Sure.
One of the issues about wider testing, and I'm speaking about the gold standard test, which is the reverse transcriptase PCR test. And the ideal swab really is from tracheobronchial lavage, but in a common situation, you try and do nasopharyngeal swab or oropharyngeal swab, and more people now are accepting anterior nasal or middle turbinate or inferior turbinate swabs, right? The issue now with getting it, and if you've been following the news recently, you would have caught wind of this, isn't just the expense, it's the ability to do the test. If you're just looking in terms of the limits or the capability of the PCR machines, and you have some in the public sector and you have one private sector entity now that does a PCR test, and you have a couple others that want to come on stream, you should have the ability to do thousands of tests per day. But you have, in terms of doing a test, you have to have the people to do the test. You have to have the PPEs to do the test. You have to have the particular swabs, transport media. For the PCR machines, you have some little plastic pipettes that you use to help to process the sample and so on. And because of supply chain issues now, they're down to about, certainly in the private sector, I'm not going to talk about what government can do now, maybe about 150 or so tests a day, 3 days a week. And that's because they can't get all of the things necessary to do the tests. Now, you would have heard about the embargo or the fact that one of our neighbors to the north, one of those civilized countries, was banned the export of things outside of their border to other countries. So I can tell you, we've had cases where we're trying to get shipments coming in to deal with COVID, not just PPEs, but stuff to do with testing and so on. And they reach certain places and they're hijacked. So yes, God, it's true. Ideally, you want to be able to do wider testing, but it's not just a question of cost. No, I've been advised by expert advisors that you also need to look at, in terms of wider testing, you need to look at issues like the yield of it. Brian mentioned in terms of the billions of dollars that we spend on testing. Most of our tests now will give you negative results, right? And based on the community, the phase of spread you are in, if you just throw tests at everybody, you're going to be wasting billions of dollars of resources. You subject persons to potentially contracting the virus because, doing the test is risky and so on. So it's really not just a question of the expense. I think you really do need to have a targeted approach, and it has to be done within the constraints that we're under.
So another thing that I need to kind of add to that, Dr. Rattray, you may be right. I don't know. I haven't seen any studies. Maybe that's what we need to do, is to do a proper analysis of the cost of doing it one way versus the long-term cost of doing it the other way. One thing I know, though, is that what they've decided to do is to spend some money on having adjustment of behavior. And that is the way that they're trying to actually contain the virus. And that is actually less money than, sort of testing everyone. And just remember that if you test everyone today, right, if you take chasing the virus as the plan, then pretty much you'd have to test everyone every day. So you'd be doing 3 million tests a day.
There are some countries that have, as a policy, decided to test all of their population. Those countries that I've seen tend to be smaller countries, and they tend to be countries with relatively low density populations. And so they were able to do that, but they also incidentally had fairly disciplined populations who adhere to the mask wearing and social distancing and that kind of thing. So whether it would be the best approach in our setting, I'm not sure.
But I think the conversation needs to spread. You're speaking from the government perspective. When you're a private institution and there are a subset of the population who feel that they have a right to be tested based on where they sit in the socioeconomic strata, how does that fare with a private institution saying we can do that? I mean, we have to balance it across the board, but at the same time, you should offer from an ethical perspective, if I want to be tested, if I think I may have contracted or doesn't want to know, should that right be taken away from me to do so if I can afford to do it?
No, well, definitely. The issue now, with the private labs really is getting private entities that can do the gold standard test, or a test that, when compared to the gold standard, has been found to be satisfactory. I can tell you that you have tons and tons of tests that came out on the market from March, April, right? A lot of people approached me, and all of them have literature that tell you that the test is 99.9999% specific and sensitive. But in terms of them being validated by other independent bodies, you find that it's not really that way. Antibody tests, for example, have not been shown to be reliable enough for clinical use. It is used here, but I think the epidemiologists are using it as a part of a process of validation. And the same thing with a rapid antigen test. If you are asymptomatic, the rapid antigen test gives you sometimes 50-50%. So Lyndon, it really depends. I mean, if you have private entities that can provide reliable tests, then sure, but that isn't the situation. No.
One additional thing, though, Andrew, that I don't think anyone is taking the ministry on with. I mean, I'm not a taker honor of the ministry, but this is important. If Andrews does an antigen test, for example, there has to be a very, very strong communication between itself and the Ministry of Health and Wellness to report positive. In the case of the antigen test, if it is negative, you are supposed to corroborate that with an RT-PCR test, PCR test. So that part of it is almost as strong as offering the test. Because if you get a positive test, are you going to do the contact tracing? Are you going to, sort of get the community involved, get the community quarantine and so on? No, you're not. So the ministry has to be very involved.
Yeah, and I know that with respect to the antigen tests, I think there are a number of private facilities that have been, I don't want to say approved because I don't know what has been announced publicly, but it has been announced publicly that they were seeking to partner with private entities to do the rapid antigen tests and also to do testing or swabs to be sent on to a PCR lab that can run the test.
Yes, I think everyone that does antigen testing and PCR testing has to submit their information to the Ministry of Health for the appropriate follow-up, etc.
Yeah.
Yeah,
That
I
you're
think
doing it
probably about
without-
8 or 9 entities,
Yes,
are kind of in the frame to be up.
Most recently, yes. Most recently, as of Thursday or Friday, there was 9
Andrews is
entities
in it.
now.
Yeah.
Andrews is in it. So, and that link to report all tests, whether negative or positive, but the positive, of course, needs to leapfrog the negative to the Ministry of Health. Where we
No,
submit
but the negative,
timely.
because of the low sensitivity of the antigen test, the negative is almost as important. If you have a good reason to actually suspect, like if there's a contact or something, and you did it, and it was negative, you have to send it off to the ministry.
Yeah, they
And
always
remember,
go.
the
Every
antigen
day
tests,
they submit them.
the antigen tests that we have should be utilized on persons who are symptomatic.
Symptomatic.
So it's really not appropriate for screening. I can't use it for pre-op. If a patient comes to me in my office and said, "Doc, I just want to know, I don't have any symptoms, but I just want to know," it would be inappropriate to send them for the antigen tests currently. Well, certainly the antigen tests that we have here.
I think that's a very good ethical question, and it's a question the ministry asked Andrews. The question goes back to the gatekeepers, are the doctors, because I can go to you and say, "Doc, just do a test for me." You'll do the test, or you wouldn't do the test. The question is, the doctors need to stand up and say, if you don't have any symptoms, and when they take the history as to why you want the test, just because you want to know, should deny you the test if there are any link, if there are no links. And that question goes back to the physicians as the ethical barrier, the gatekeepers for COVID.
Right. We have one more question.
I was about to say, I'm not even sure if we have time to do one more question.
Okay.
Dr. Brown Morgan is back as the moderator for the session.
Sure.
I would hand over to her. Thank you, Dr. Swaby, Dr. Manning, Dr. James, Dr. Leach.
Thank you.
Thank you, panelists. Wonderful job. Appreciate your perspectives.
Thank you.
Thank you.
Indeed, I'd like to second that, Dr. James. It has been an active and vigorous session with a lot of debate, and there are lots of issues I think that we probably have not been able to get to this evening. It really, really needed to be scheduled for a bigger, I think a bigger session, because this is such a topical and important area. Thank you, gentlemen, all for participating. And at this time, we are about to close for the evening. And it is my pleasure to again invite Dr. Peter Swaby to give the vote of thanks on behalf of the General Practitioners Association of Jamaica. Thank you.
Hello,
Arna.
Sam.
Thank you very much for
Sam.
thank you very much for moderating this session. Thanks to all our panelists. We have had a wonderful day. From judging from all the comments, everybody has been very satisfied with the level of presentations and the information received. I want to thank each of our presenters, Jennifer Knight Madden, Rochelle Roman, and Angela Scott, all excellent, well thought through presentations that have really helped us, especially as general practitioners, to know how to navigate treating our patients and referring appropriately, and what to look for. We're so grateful that you took the time out. To our panelists on the ethical discussions, we could go on all day, but you've all shared very pertinent and relevant concerns. I'm sure we, as general practitioners, as well as other physicians, share the same concerns. We're going to have to really think through the next 2 years at least on how we manage our practices and how we go forward in treating our patients as efficiently and as cost consciously as possible. Thank you so much, Andrew, Brian, and Lyndon, for your presentations and your comments. I do want to thank our moderators, Aldith, Buckland, and Arna, for moderating and keeping us on track in terms of time. Thank you to the executive, Donald Gordon, and the executive of the AGP for coming up with these topics. And we also want to thank Lynn, who is our administrator, who does a fantastic job in making sure that everything comes together at the end of the day. And we cannot leave without mentioning Sam Heron, who makes sure that our online presence, as well as all the technical issues, are worked out. Thank you to all our participants for logging in, joining on. We look forward to seeing you at the next AGP seminar sometime in April, and have a great afternoon. Thank you so much.
Thank you very much, Sam. Just like to add my thank you to all the attendants and the participants in our first webinar of the year. It was very interesting and informative. And thanks to all the panelists and presenters and the technical team as well. And we look forward to you joining us and your continued support in the upcoming webinar in April. And we are very happy for the level of turnout and sponsorship that we have been receiving at the webinars. And please continue your support, and thank you, and enjoy the rest of the afternoon.